Okay. So one may ask, I'm sure you have been to the hospitals or you've heard of diabetes before. Um, I would want us to start with a recap, or I would want to find out from the class what your knowledge regarding diabetes is all about before we start today's presentation. Let's show. Mm-hmm. Diana,
Madam,
what knowledge do you have about diabetes mellitus?
I know it's a sickness about high glucose level, whereby if a person having diabetes gets a cut or a wound, it doesn't easily heal.
Oh, that's good. So meaning that if patients with diabetes,
That the person,
the wound doesn't heal faster. That's, and then you also talked about it's characterized by high blood
yes,
level. That's it. Franklina Buff Benefo.
yes.
Okay.
Madam,
Mm-hmm. What do you know about diabetes? Or what have you heard about diabetes?
um, diabetes is a type of disease whereby a person has high blood sugar
I think
um,
Diana has mentioned that. Mm-hmm.
due to an inability to produce
Mm-hmm. To produce what?
insulin.
Okay. That's also
Like
very,
insulin they produce is insufficient.
it's insufficient. Okay. So it can be both. It's either your system it cannot produce the insulin at all, or the insulin that is produced is insufficient, or your system, the insulin might be producing enough, your system might be producing enough insulin, but you realize that your 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 tissues are unable to reuptake the glucose that the insulin has converted into. The insulin converts the sugar or the fructose into glucose for reabsorption to take place. And so once the glucose is in the system, there are instances that your tissues would refuse to reuptake the insulin in the system, and that can also bring about high glucose level in the blood. So at the end of the day, the three of you or the two of you have spoken it all regarding what diabetes is, meaning that diabetes is characterized by high blood glucose sugar in the blood, high glucose level in the blood, and it is due to inability of the body to produce insulin. That is the first point. The second point is the insulin might not be sufficient, and the third point is the insulin might be present, the glucose insulin may be present, would be functioning well, but your system or your tissue would refuse to reuptake the glucose in the blood. Once your tissues do not take the glucose in the blood, what happens is that it allows accumulation of this glucose in the blood, hence bringing about the high blood glucose levels in the blood. Okay. So now let's go straight to what we intend doing. From the recap we have just done, let's go from there. Go. Try.
Hello, sister.
Hello, dear.
Yeah, please. Some of them are saying they can't join. Or they've been trying, but they can't join.
Is it with
I
the
don't know
same?
what is happening.
Yes,
Is it the
yes.
same link?
The same link.
The
Emma is
same link.
complaining that she can't join. And
If
Wendolin too.
Gwendolyn sent it to me and I was able to join, but she's complaining she's not able to join.
And then let me check. I don't know.
Emma, you've joined now.
Probably it might be internet problem because I didn't allow myself to. I didn't allow participants to remain in the waiting room. So I'm wondering why they are unable to join. Please, has Gwendolyn been able to join? Tell her to restart your whatever she's using and
Yeah,
let's see. Send her a message and tell her to restart. Go and brush your teeth and go. Please tell her to probably restart her PC or computer and phone, whatever it is.
okay.
So diabetes is just a group of metabolic disease conditions which is being characterized by increased level of glucose in the blood.
Okay.
Okay. And this is termed as when we have high glucose level in the blood, it's termed as hyperglycemia. And this is as a result of insulin secretion, insufficient, either defect in insulin secretion. And it can be due to either the insulin secretion is not sufficient, as what's her name? Diana, is it Diana who said that? As Diana rightly mentioned, or the insulin action. The insulin is supposed to help the tissue to reuptake the glucose in the blood. So if the insulin action on the tissues is unable to function properly, then there will be still high sugar levels in the blood, or both. There are instances that both are working concurrently in the same individual, and that is also resulting in the high blood glucose level in the blood. We have types of diabetes, the type 1, type 2, and then gestational diabetes, and also diabetes associated to other medical conditions. And so with the type 1 diabetes is also known as the insulin dependent diabetes or the juvenile onset diabetes. With the insulin dependent, what happens is that the pancreas itself, the pancreas is either diseased. Maybe whilst the child was born, the way we are saying is juvenile, most of the time it happens from infancy. And then you realize that you go and do some medical screening and it will come out that the pancreas is defect and so cannot even produce the insulin. Once individual is having a defective pancreas, what happens is that there will be no insulin production. Hence, the individual will have to depend for the rest of his life on insulin in able to help control the sugar levels in the blood. That's artificial ones, not the ones that your system is producing. That's why we say it's called insulin dependent diabetes mellitus. The type 2 is what we term as the non-insulin dependent, and it's usually adult onset. And with this one, the reason why it's adult onset, as people age, they put on weight, they live a sedentary lifestyle, the activity level is very low. And so once you have a lot of tissue built in your system would have the inability to reuptake this sugar level due to probably so with this one, oral medications alone can help correct the glucose level and you wouldn't have to be put on insulin. But there are instances that with the type 2, one will have to start with the insulin. Along the line, will take you off the insulin. You continue with the oral anti-diabetic drugs, and then you'll be good to go, coupled with other measures such as controlling your weight. And then we can easily control your weight through exercises and active through exercises, and then weight your food, and then also constantly monitoring your sugar levels. So if you don't eat do the diet is a very cardinal way of maintaining or controlling diabetes with this type of um, diabetes. And with regards to the gestational diabetes, that is where one gets pregnant, and because of the hormonal changes, it can predispose you to having a high blood sugar level in your blood. And with that one, after delivery, most of the time, what happens is that the individual sugar level comes back and then the diabetes is gone. But it's been projected through evidence-based facts that most people who develop gestational diabetes, later part of their life, in their adult age, have a high tendency of getting diabetes, and it comes to stay. And usually it's the type 2, which is the adult onset, because after pregnancy, series of pregnancies and hormonal changes, and you grow, at that time you are still growing. So at the later part of their life, which is the adult stage, they usually develop the type 2 diabetes. Then the diabetes associated with other conditions. What happens is that we have the other disease conditions which can predispose you to develop diabetes, especially if you have disease condition which affect the pancreas. You have organs around the pancreas. If this yes,
Please, the background noise is overtaking what you are.
I'm saying, okay, I will have to control the kids. They are just playing around. Yeah, hello. I hope it's better now.
Yes.
The gestational diabetes, should I go over again or it was okay?
Please go over again.
All right. I said with regards to the gestational diabetes, it does occur. Its occurrence is due to pregnancy. The word gestational simply means pregnancy, and the diabetes occur during pregnancy. And this is as a result of hormonal changes that occur in your system. Might bring about your inability, as you eat more. You have this propandal diabetes mellitus. After eating, your inactivity level might be low. You might have, most of them too have probably hereditary factors. And so what happens is that the hormonal changes during pregnancy will help or predispose you to have this diabetes mellitus. And there has been evidence-based facts which has proven that people or mothers who usually develop gestational diabetes, when they grow older, later in their older stage, the diabetes, they get the adult onset, which is the type 2 diabetes or the non-insulin dependent diabetes. The reason why we call it non-insulin was the reason because you don't need to be put on insulin. You can have oral anti-diabetic medication to control your sugar level. And then we have diabetes, which is associated with other conditions. You may be having other medical conditions such as hypertension and all other, medical conditions which might have direct association with your pancreas. And so we are saying that those conditions, when happened, can predispose you to diabetes. So meaning if those underlying condition is not corrected, the diabetes mellitus might also not be what? Be corrected. I did a research and most of my patients were having hypertension. And they said that they never knew they had diabetes until later part of their life. So there has been evidence-based fact that people who are also having hypertension, most of them are being predisposed to what? Diabetes later part in their life. And we have other people who might be having diabetes alone and might not be having the hypertension. So we are not saying that all types of diabetes is associated with other medical conditions, but it's been confirmed or there has been evidence-based facts which suggest that other medical conditions can predispose you to what? Diabetes. So that is the fourth type of diabetes. Okay. So the risk factors for the type 1, which are the people, when we say risk factors, which people or which categories of people can be predisposed to the type 1 diabetes? Children or people who are under the age of 30. So before age 30, if you are being diagnosed of diabetes mellitus, there's a high tendency that you might be having the juvenile onset, or you are more of the juvenile onset diabetes, which is the same as the type 1 diabetes or the insulin dependent diabetes. Then we have genetics, we have family traits. Along the line, we were learning about what are some of the predisposing factors of certain conditions. If you have a family trait which have a genetic predisposition to have diabetes mellitus, maybe my great grandfather was having, my mother is having, my twin brother is having, my twin sister is having, there's a high tendency that once any member of your family has been predisposed to diabetes, it's possible you can also be prone to having this type of diabetes. And then we have autoimmune diabetes. There are instances whereby your own system is fighting against your immune system. So if you have it, that one, usually we don't know that what really bring about that. They see your own organ as another foreign body. The antibodies see the organ there as an antibody, and they end up reacting or acting against its function, its normal physiological functions, hence predisposing the individual to this type of diabetes. Then we have environmental factors. So many other environmental factors such as diet, your lifestyle, and all that can also predispose. And then the viral infection. The viral infection too, when it affects your pancreas or the organ that needs the pancreas usually produce the insulin. So once you have viral infection of the pancreas, it can also predispose you to the type 1 diabetes. The type 2 diabetes is usually associated with older people. As I already mentioned earlier, as you age, your lifestyle changes since you build more fats that you become obese. You may be having family history of diabetes, and then history of gestational, as I explained earlier. If there is a history that you have ever had a gestational diabetes before, you can also be predisposed to the type 2. And then we have impaired glucose metabolism. Impaired glucose metabolism. The glucose in your system is unable to be metabolized due to certain factors. So once that's metabolism simply means the process of it being reused by your system through an activity that goes on. So once that hasn't been taking place, the glucose will still be accumulated in your blood, bringing about a high blood glucose level. Then physical inactivity. So individuals, we have so many individuals who do not take the essence of physical activity very serious. And we are saying that if you are that type, you should look out, especially if you have a family history and then you still have that lifestyle of not being active, can also predispose you to that type 2. And then again, race or ethnicity. We have some kind of group of race, such as the blacks, being more, if you are comparing the blacks and the white, Hispanics, and all that, we have a percentage being allocated to each of these race, hence predisposing them tomorrow to the type 2 diabetes. Then came out with the African Americans, the Hispanic, the Latinos, the American Indians. All these categories are particularly having a high rate of the the type 2 diabetes. If you look at their lifestyle, you know how they eat. Some of them does eat junk food and all that. And you can see when you are watching this program, you can see some very obese. Their weight is so enormous that you can't even. It doesn't correspond to that of a mechanism. I was just watching something that I was born different on, is it Facebook? But when I look at this individual and I was asking myself, your lifestyle has predisposed you to it. You weren't born different. You can't put it on Facebook and be telling people that you were born different. He has grown so fat that you can lift the abdomen alone. The layers on the abdomen is more than 5, or is it 3? The arm, there are so many layers accumulated. And then he was like a burden to the kids. And then eating all sorts of food. If you are living this lifestyle, of course, diabetes cannot leave you alone, would surely come and visit you and stay with you for the rest of your life. And that would also call you to your grave at an earlier stage. That might not be the time that God really wants you to be called. We have the risk factors for these type 2 diabetes as well. We talk about aging, overweight, hypertension. I mentioned that other medical conditions such as hypertension can predispose you to it. Abnormal lipid levels, genetics, race, ethnicity, history of gestational, history of vascular disease, and inactivity. Very, very important. And then with the gestational diabetes, it's a form of glucose intolerance that is diagnosed in some women during pregnancy. So once we have high glucose level during pregnancy, that is what we term as the gestational diabetes. It is also more common among obese women and women with family history of diabetes. And during gestational diabetes, it requires that treatment should bring about normal of the glucose level to avoid the infant. Women who usually have gestational diabetes will give birth to babies who are they say macrosomic babies. That's the huge babies above 4.5. If you are giving birth to such babies, you should check out for your own sugar level as well. Most of the time, you realize that those who are giving birth to huge babies, some of them normal weight of babies should be between 2.5 to 3.5. Currently, I think it's 4.0. I'm not so sure. Would have to check that. And once you exceed the normal baby's weight, your baby, because of the high glucose level, the baby also tends to grow bigger and bigger. And hence, you end up giving birth to macrosomic babies who are so huge. And the women have had gestational diabetes have about 20 to 50% chance of developing diabetes in the next 5 to 10 years of their life. I mentioned that as one ages. So now we've gotten the exact figure, around 5 to 10 years of their later life after you were diagnosed with the gestational diabetes. There is a high percentage level, around 20 to 50% chance that you end up developing diabetes in your later stage of your life. Then diabetes due to other disease conditions. That's the fourth one. And we have acromegaly. That's another condition, the Cushing syndrome, the thyroid toxicosis, the pheochromocytoma, chronic pancreatitis, the cancers, drug-induced hyperglycemia. We have certain medication. The drug-induced hyperglycemia are medications that when you take, it ends up shooting your sugar level. An example of these drugs are the atypical antipsychotics drugs. We have some antipsychotic drugs, people who are having psychological problems and being put in on psychotic drugs. Some of the medication does increase their sugar level. We have beta blockers that inhibits insulin secretion. Medication, these beta blockers are being administered for people with heart conditions. So we have the same as the calcium channel blockers, the corticosteroids. The corticosteroids are just hormonal, more of hormonals, and then cause peripheral insulin resistance, and then glyconeogenesis. So the insulin resistance is the tissue itself would be made resistant to reuptake the insulin in the system. Its impact on the tissue would prevent its uptake of the glucose, hence bringing about the sugar level in the blood. The niacins, they cause increase in insulin resistance due to increased free fatty acid mobilization. They are all medications, so you put it at the back of your mind that we have other medications which can predispose or which can induce high sugar level in the blood. Hwɛ akwadaa no ɔnyɛ sallah, nyɛ saa mehwɛ o. Yeah. The clinical manifestations of diabetes, we have usually the 3Ps. The 3P stands for the polyuria, polydipsia, and polyphagia. When we say polyuria, it simply means increased urination. Poly is increase, urea is urination, so very simple. Polyuria. Polydipsia, increase in what? Tests, or increase in when you have access or you have appetite for more fluid or water. And so polydipsia, you have this increased tests, which will bring about you taking more water in your system or drinking. There was a patient I nursed when I was a student back in the NTC. This patient said she could urinate, she could drink as much as the 5-liter gallon, and then he will urinate more than 2 of the 5-liter gallon. In as much as she's taking more water, she was also urinating more. Hence, that was the bringing. So usually when there is polydipsia, there will be what? Polyuria. This is the link. And then polyphagia, there is increased appetite. Once one gets hungry, the person eats. Another patient I had, this was during my master's, the interaction, she said she gets so hungry that when she's eating, it's like the hunger pushes her to eat at a very faster rate that she herself, sometimes when she's even in public, she's not comfortable. So there is increase in appetite, hence bringing about them eating more. And once they are eating more, it ends up also they also end up increasing more weight. There'll be more fats deposition in their system, hence they'll be increased in weight. That's why among the management, there is a need for one to check the weight through exercise, and then also monitoring the sugar level for the management. Now we have other clinical manifestations. There is fatigue and weakness. There's also vision, blurred vision. There is also tingling and numbness in the hands and feet. And then dry skin, wounds that are slow to heal, and there is recurrent infection. Usually the wounds, as is it Diana who said that? I've forgotten whoever mentioned that. That they have wounds and sometimes it takes a very long time to heal, as much as months. It doesn't heal. And this has its own underlying factor due to the high sugar level. You know, when one has high sugar level, it has so many diverse effects on the entire system. Are you here? Wonderful. Oh. Fifi ha wunya akwara kọ. Yedi na me chat me pay the step as what. Yedi net na say. We na be throw questions, throw questions to one be say question later. Akwara keso a work class 6, class 5. Abet na ha me chiri mpanyimfo ade just to be bisa question. There's also wounds that are very slow to heal, and we have recurrent infections. They are being predisposed to systemic infection due to the immune system that their immune system gets weakened. And so we have other opportunistic infections that usually also they become prone to. We have criteria for diagnosing diabetes. Before you can now say that this patient is being diagnosed of diabetes, there should be some cardinal things that one must look out for. And among them is the 3 P's, the clinical manifestations. You don't rule that out. Once someone mentioned those 3 clinical manifestations, plus these ones, that's you check the glucose level, and you realize that the glucose in the blood is either equal or greater than 11.1 millimole per liter, then it means that individual, we can now confirm that this individual is having diabetes mellitus. Now, this is for the random blood sugar. But with the fasting blood sugar, the random blood sugar is during the day what happens. But fasting blood sugar, the person is made not to eat throughout the night till the morning that you check the glucose. And so with the fasting blood sugar, it shouldn't be greater than 7.0 millimole per liter. Nina, wunya akwala, uja kwa meshawati. Sure. So she mentioned her. No, but I'm there before abu. We must say the day na ekoso na. Sorry for the inconvenience. With the fasting blood sugar level, it shouldn't be more than 7.0 millimole per liter. Then the 2-hour post-load glucose level, that's what we also term as the postprandial glucose level. That's at 2 hours after eating. 2 hours after eating, you also check the glucose level, and that shouldn't also be greater than 11.1 millimole per liter. Once this happens, you can now confirm that this individual is having diabetes mellitus. Plus the 3 P's, which is very cardinal. These are the cardinal, the polydipsia, the polyuria, and the polyphagia. Where the polydipsia is excessive thirst, polyuria is excessive urination, polyphagia is excessive appetite for food, hence to eat more. And let's look at the complications of diabetes. We have the acute complications and we have the chronic complications. With acute, we have the diabetic ketoacidosis. So in each, we have diabetic ketoacidosis, whereby we have keto bodies in the urine and it has a sweet smell. That's a fruity, it has a fruity smell, ketoacidosis. So those who are having, if you are there now, achievement, you have to run, it's a complication of diabetes. Urine is supposed to have a pungent smell, but once your urine is having a sweet smell, fruity smell, then it means you may be heading towards a complication of a diabetes, or probably it might also be another clinical manifestation of another condition. And then we have diabetic hypoglycemia. That is when the sugar level also gets so low. You take the insulin, 30 minutes you are supposed to eat. Some will take the insulin and would forget to eat. Once you forget to eat, what happens is that you can easily go into hypoglycemia, and then that can lead you to coma. The diabetic ketoacidosis too can also end up leading you to a comatose state. You may end up being rushed to the hospital. And that's happening so suddenly. That's why we call it acute. It doesn't take time for ketoacidosis to occur or more, as well as the hypoglycemia. It takes just a few minutes. If you miss the time, if you are caring for patients on the ward and they are diabetics, make sure their food is ready before you even inject the insulin. Because if you take that for granted and you inject the insulin thinking that meanwhile you know there is no food on the table, you end up killing a patient who whose time is not due. And I've always been saying this, that we have the armed robbers out there using guns to kill patients. The nurses are also using injection to kill patients. And so at the end of the day, if you are both standing in front of God, you are all killers. And so the work that we are doing, there is some few things that you can do that can cause the life of an individual. Hence, the need to make sure you protect your patient's life at all times. And so anytime you know your patient is on insulin, make sure before you give the injection, you find out, do you have food on your table before you even inject the insulin? Because that can predispose this patient to hypoglycemia. And that hypoglycemia, within some few minutes, the patient can go into comatose state. And if it's not rectified, the patient will die within those few minutes. And that is very, very, very dangerous. We have the chronic complications. With the chronic, it takes a very longer time before it does okay. And we have the macrovascular complications. And this one, we have the nephropathies. The nephropathies, that is where the nephrons, you know, you're unable to urinate properly, can even affect your kidney, anything that has to do with your, and it ends up having you also developing kidney failures. Any patient who is having diabetes mellitus can have nephropathy. The kidney becomes affected and they end up getting kidney failures. And the retinopathies, it affects the retina of the individuals. Hence, that can bring about the blindness in diabetic patients. So most diabetics, once they start complaining of blurred vision, the first thing that should come to your mind, don't just tell the patient, oh, it is normal, what diabetes internal. Please refer the individual straight to the ophthalmologist. Refer these individual straight to the ophthalmologist. Once your patient start telling you, I have blurred visions, I cannot see well, the ophthalmologist will have to come in, check the retina and do the necessary checks and protect your patient's eye. Otherwise, that can also lead to blindness, total blindness. Once there is total serious retina damage, there is nothing, it's irreversible, and that can lead to total blindness. So please, as you are caring for your patient, when they come with blurred vision, quickly refer them to the ophthalmologist. And in health, there's one thing that we fail to acknowledge, that we are working as a team. We work collaboratively with um, um, other specialists. And so we work as a team. If you have any special um, problem that your patient is having, make sure you refer to the appropriate quarters for the specialist to also continue his work. Not everything that is medical, not everything that is surgical. There are other things that need special attention, such as the eye, the ears, and all other parts of your bodies. And we have neuropathies, the neurons. When your your nerves are being affected, they lose sensation. That's where we have the numbness at the foot and then the feet. And so once the patient tells you, I have more numbness on my feet, what you need to do to also refer this patient to the neurosurgeons or the specialists in those who take care of the neurons. And in at the advanced hospitals, they have podiatric nurses. The podiatric nurses, what they do, unfortunately, here in Ghana, I'm yet to find one. I don't have anybody in mind that I can pinpoint that this person is a podiatric nurse. The podiatric nurse is a person who cares for the foots for diabetic patients. So once you come in and you complain of numbness, loss of sensation of your foot, what the person does is that the person does nerve assessments or does assessment of the foot to rule out any neuropathies, and if there is any remedy that needs to be given or any education that needs to be given to correct that problem, they come in and then they do the needful to correct that mishap. Then we have the macrovascular. The macrovascular disorders, we have the heart condition, the ischemic heart condition, the cerebrovascular disease, and the peripheral vascular disease. All these are cardiovascular problems, and we are saying that the cerebrovascular is more of the brain, the heart. We call it stroke. It's the same as stroke. That is another complication. So in simple term, it's also termed as stroke. The cerebrovascular disease is also termed as stroke. The ischemic heart disease is a heart. When we do heart problems, we come to appreciate what it is. So we should just remember it is a disease of the heart. The peripheral vascular disease is also disease of the blood vessels, the peripheral blood vessels. So all these disease conditions are the more of an advanced complication of the diabetes mellitus. So these are just the details of the nephropathy. I talked about the kidney diseases and what does happen. Yeah, they do. Watch it. Okay. So regarding the neuropathy, this is just the detailed actions that happen. More of which is an regarding the complications of diabetes mellitus. And the fact is, once there is high blood sugar level in the system, it does put more extra stress on the kidneys. And as this happens, if it does happen and you realize it earlier, what happens is that you can be given remedies. Remedies can be put in place to correct this anomaly. Then after some years, what happens is that it damages the kidney and it starts to leak. You know the kidney has a filtration and function. And once these useful proteins are lost through the kidney, you end up getting a disease condition which is known as the microalbuminuria. You urinate and they find urine in your albumin in your urine. And so when you go and do urine RE, they would be able to get urine in your albumin, which signals that once there's urine in albumin in your urine, it signals that there is the kidney filtration has been tampered, hence bringing about the albumin in the urine. And this, when when you are able to detect it early, you can easily correct it. Naima Michas. So what I'm saying, I was saying is that once there is high blood sugar level in your blood, it puts extra stress on the kidney, or it troubles the kidney such that the filtration function of the kidney becomes tempered. Hence, the ideal thing is that the useful protein in your system is supposed to be reabsorbed into your system so that your body uses it. But if this is not taken care of, and then this urine passes through the kidney, you end up having microalbuminuria. Thus, you take urine RE, there will be albumin in your urine. Again, if it's found earlier, at this point, you can be given treatment to correct this anomaly. But if it is not found early, or you do not report early with this deformity, this anomaly, what happens is that the kidney, if it's being diagnosed later stage, what happens is that it can result in end stage renal disease. And the end stage renal disease usually follows that the kidney lose its filtration habits. And once the kidney lose its filtration ability, the waste product then ends up building up in the blood, you know, is unable to filter the toxic products from your system. And this toxic ends up builds up in your blood. And once it builds up in the blood, poisons ends up destroying your cells. So it will destroy the cells of the kidney, bringing about kidney failure. The kidney ends up failing. That is what I mentioned earlier. That can bring about your kidney failure. And once your kidney has failed, the way forward is either we have kidney transplants or you'll be put on dialysis, and that is very, very expensive. Being put on dialysis and being taken care of every day by your family is also another form like cancer. Family members get tired, it will drain all your cofex, and this is a lifetime maintenance treatment. And it's not every family that can even afford to come to the dialysis center for this kind of transaction. And again, it's not every family that can afford for kidney transplant. So it means if your kidney fails and you don't come from a rich home, what happens is that you would be left to die peacefully, managed, and will give you the normal palliative nursing care, and you have to die peacefully. Retinopathy. Over here in Africa, that is what happened. But in outside the country, here the government also supports their people. What happens is that these individuals are being taken care of, and sometimes we have other benevolent people who also takes care of these kind of charges and all that. Like here in Africa or here in Ghana, I can talk for Ghana, we can't talk of Africa as large. Is the rich who are able to, do this kind of treatment, dialysis plus kidney transplants. You have to travel to India or other countries. And there are times even the rich people cry, they also solicit for help. They will tell you you have this amount, we can't take care of the entire cost. Then they will now put it on the media, TV stations, WhatsApp platforms to solicit for funds. And look, actually, sometimes they will finish doing it and the patient or the individual might not even survive. It's so pathetic. So we just pray that God Almighty protects all of us from this kind of complications. Retinopathy. I mentioned that the retinopathy can also lead to total blindness. And this is as a result of the high blood sugar in the blood. There are several factors that influence whether you get retinopathy or not. If you have good sugar control levels, you are rest assured that retinopathy will not be an issue. If your blood pressure levels is also normal, you are also rest assured. How long you have been on diabetes? There are times that people are on diabetes for a very long time and did not complain of any complications. This is as a result of the normal blood sugar levels and the normal BP levels that these individuals do have. And then again, if you don't have genetic factor of any retinal problems or a eye problem, that one too you can be rest assured. Almost everyone with type 1 diabetes will eventually develop non-proliferative retinopathy in their lifetime. So this is just an evidence-based facts, which suggests that most type 1 diabetes usually eventually at their later part of their life develop retinopathy. So this is an individual, a baby or a child. This is the normal vision. That's how you see it. But those with the retinopathy, they see it as we see clouds, blood, not just normal blood vision. But when say like they see it like clouds, or they see that bloodness, This is how the child should see it normally, and this is how this individual is seeing it. So this is just a picture to show you how retinopathy looks like. Then the nephropathy, that's the nerve damage. 50% have some form of nerve damage. In some, more common in those who have heart disease for the many years. So usually those who have the condition for about 25 years and above, or 20 years and above. Others, for example, if their sugar level is not well managed and it's around 5 years, they can still develop the retinopathy, because the underlying cause of these complications is due to improper management of the sugar level. So blood glucose control can help prevent or delay the nerve damage as well. So the same ideology is applicable to all the forms of the diabetes. The two common types of the nerve damage, we have the sensory motor neuropathy and autonomic neuropathy. We have two main types of nerve damage, the sensory motor and then the autonomic neuropathy. The sensory motor neuropathy is also known as the peripheral neuropathy. And then the peripheral neuropathy is usually can cause the tingling. The signs or clinical manifestation of the sensory motor neuropathy is the tingling sensation, the pain in the foot of the arms, the thumb, the fingers. We have weakness, and then in the hands and the fingers. So these are the tingling sensation, the pain, the numbness or weakness in the hands and feet. These are signs of peripheral neuropathy, the peripheral neuropathy or the sensory motor neuropathy. Now we have the autonomic neuropathy, and usually this can lead to digestive problems such as feeling of fullness. What's also a common deme, the whole day from morning till probably afternoon, getting to evening, this patient will be telling you, I don't feel hungry, so I'm not eating, and all that. Feeling of fullness. And other places too, the patient might have nausea. So if you are individual of that nature, please go and check your neurologic system properly. You are always complaining of nausea and all that. There are times the patient will also feel like vomiting, will have diarrhea or constipation. Problems with how well the bladder works. There are times that this individual might be having kidney problems, the problem of having sex, loss of sex drive and all that, dizziness or faintness, loss of typical warning signs of heart attack, loss of warning signs of low blood sugar level, your sugar level will be low. It's supposed to make you feel some way, like you don't feel fine, and then there are no warning signs. Increase or decrease sweating. If the individual has excessive perspiration or doesn't sweat at all, even after a hard day's work, it calls for concern. And then changes in how your eyes react to light and darkness. If you are in the dark and there is light all of a sudden, your eye is supposed to adjust itself to accommodate the bright light. If you're unable to do that, it's also another concern that needs to be checked. Then we have the macrovascular complications. We have this, I talked about, these are all heart diseases, the stroke, and then the peripheral diseases. The diabetic patients have 2 or 6 times higher risk for developing these complications than the general population. So if someone is not diabetic, the rate at which he will get ischemic heart disease, the stroke, and peripheral vascular disease is 6 times or 2 times higher than someone without the diabetes. So that is all it's saying. So at this point, we'll end here. Hey, I said we'll end here. Let me just look at how the diabetes affects. We will not really go into how it affects the heart disease because we'll be looking at that pretty soon in the cardiovascular system. So okay, this is how, maybe let me just briefly explain to you how it does affect or how it brings about the heart disease. If someone is having high blood sugar levels in the system, why it does it causes narrowing or blocking of the blood vessels. Once these blood vessels supplying the heart is being narrowed or blocked, it can bring about the ischemic. When we say ischemia, I hope you all know that ischemia is all about what? Cut off of blood supply to a side. That's what ischemia is. So ischemic heart disease, because there's cut off of blood and oxygen and nutrients to the heart, that is how the ischemic heart disease. Okay. Ouch. Please, there's no battery, so I'm trying to reconnect the main source. Thank you. Yeah, hello.
Hi.
So we are looking at how diabetes can result in ischemic heart disease or stroke. And I'm saying that what happens is, someone who is having diabetes usually does have lots of fat deposits in the system. These fat deposits can either be accumulated in the blood vessel, bringing about either narrowing of the blood vessel or total blockage of the blood vessel. Once there is total blockage of the blood vessel or narrowing of the blood vessel, what happens is um, the individual, the individual, they'll be cut off of blood supply to the heart. And then once there is cut off of blood supply to the heart, we know the blood consists of nutrients and oxygen. So it means the heart will be deficient of nutrients and oxygen at that point due to the total blockage or partial blockage. And this will now end up resulting in ischemic heart attack or ischemic heart disease, or you can also talk about ischemic, another name for sorry, the ischemic heart disease, not the stroke, sorry, is the same as heart attack. The same as attack. Heart attack. Okay, that's the local term. So the heart disease, which is also termed as the ischemic heart disease or the heart attack, it brings about due to narrowing, either partial narrowing or total blockage of the blood vessel. And once there is blockage of this blood vessel to the heart, what happens is that it's being denied or it's become deficient of oxygen and nutrients. Hence, there will be ischemia. And once there is ischemia, it means that ischemia simply means dead tissue. The heart tissue will be dead, and then that will bring about the ischemic heart attack. So there will be total cut-off of blood supply to the site. The heart will have ischemic heart disease, which is the same as the heart attack. So that is how it does happen in diabetes. Diabetes increases the risk of the coronary artery disease and heart attack or stroke. And then to prevent these steps, you have to keep your ABC of diabetes on targets: the airway, the breathing, the circulations. So make sure your patient is always having a very good airway system. The breathing is very accurate. If you're checking the vital signs and realize that the breathing is very poor, please quick and then react accordingly. And then if the circulation is also not that good, you can also put in some measures to correct it. And then we have the foot care. I mentioned that in advanced stages or in advanced countries, we have the podiatric nurses who do daily checks of the feet. Here in Ghana, our nurses are supposed to be trained to know how to check the foot of our diabetic patients, being it at the district level or at the teaching hospital or wherever they find themselves, because we don't have them in the system. So you have to keep always also the foot wound can also be reduced through proper checking of your foot, daily checking of the foot, and then so daily check of the foot. What you have to be looking out for, look for the cuts. Do you have any cuts around the foot? It could be a slight cut, please check. And then make sure you dress it aseptically to prevent the wound becoming bigger. As someone said, with patients with diabetic wound, sometimes it lasts for a very long time when the sugar level is also not in control. When you find blisters, I did a study on diabetic foot condition, the experiences of patients having diabetic foot disease for my master's level. I love diabetes so much. I'm passionate about diabetes conditions. And I hope in future I might open a diabetic center to train more nurses to have a better way of caring for patients with diabetes. And so with this study, what I found out was that most patients really didn't know they had diabetes until they developed some blisters around the foot. One patient said he woke up and there was blisters all over the foot. So she quickly went to the hospital. They cleaned the wound. They thought it was cellulitis.
Okay.
You know, cellulitis also have similar way of developing. And so they treated for cellulitis. The patient came back, it went down, and it resurfaced again. Just later in life for them to realize that it was diabetes. Another patient also said that she was there, she didn't even notice someone, and she has even wound. She didn't even see the time that the wound developed. But the wound was at the sole of the feet. You know, when you have a wound at the sole of the feet, because of the neuropathy. So because I have a background of understanding how the physiology of diabetes, I realized that it was because this patient had a neuropathy. You know, when you lose sensation of the foot, when something pricks you, you may not even know. When something cuts you, you may even not notice. That's why in our olden days, our nurses were advising diabetics to be wearing socks, especially those who go to farm. If you wear socks, if something pricks you and you can't hear, at least the socks will serve as a protection to prevent you from being hurt. Or you can wear a protective shoe that is not so hard, or that doesn't fit your leg so tight, so that it can serve as a protection for your foot if you can't feel any pain around the foot, you know. And so that idea of that blister formation was another cardinal thing that reflected throughout the participant that I studied. So whilst you are those who are still practicing, if a patient comes to you and he's talking about blister formation around the foot, I would encourage that you please tell the person to go and check the glucose level. Very, very important. And then after the person has checked and is still negative, tell her in a month's time, she should come and check her till 6 months' time. Because what I observed was that some realized it after the sugar level became high after the 6 months' time. Meanwhile, it wasn't that they were not having, but probably it wasn't so high that our glucometer could detect. You know, we don't have that advanced type of glucometers that can easily detect certain things. And sometimes some other patients talked about red spots. It's like blood accumulation around the foot, you know. Others also talked about swelling. I mean, he doesn't know what brings about the swelling. He doesn't understand why the swelling is happening. He doesn't have any medical condition yet. He's having swelling of the foot. So once these things are coming up, please don't hesitate to refer them to check their glucose level. Use a mirror to check the bottom of your feet, or ask someone to help. You know, the bottom of your feet, not everybody, me for instance, I don't even have time to be doing those things, you know, but it's a very good habit that we entreat all of us to start doing it, myself included. Checking your feet, around your feet, beneath, under your feet as well, because one patient said it is under the feet that he noticed that he had a wound. And when he was dressing, when he dresses the wound, he doesn't feel any pain, so he decided to boil water, but he didn't really check the hotness of the water. And then he kept the foot, he tried putting the foot inside. When he kept the foot, it was so sweet. Because we lose the sensation of the foot, he was rather feeling sweetness in the wound. As I ended the he's now feeling that the heat was making him enjoy the hot water. So when he kept putting the leg in until the hot water caused burns on the foot, you know, and then later he had to be admitted at Konfanochi because the wound was still not healing. The wound has also extended around the foot because there was burns, hot water burns. Whilst enjoying the hot water under the wound, under the feet, the hot water splashed on the foot, and so there was now burns around the foot which needed to be taken care of, you know. Then also encourage them to use warm water, not hot water, as I've rightly mentioned. Warm water is okay. Warm water to do the cleaning. And then dry well, especially in between the toe. When they are drying their foot, make sure they dry in between the toe, because most patients who are having foot ulcers also started around the toes, you know, especially the big toe, such that the big toe becomes so black, and it sometimes even ischemic. There's blood cut off of blood supply to the big toe, and sometimes it was even cut off. Most of my participants' foot, the big toe were cut off, you know. So we are saying that in between the toes, make sure you take proper care, and then you clean it dry. That is for the foot care. Now you keep your foot soft and smooth. So after you have dried it, you can apply lotion such as shea butter, the Vaselines, the any lotion that we think has a very good soothing effect to the foot. You apply it on the foot. And do not use lotions in between the toes. Lotions for the toe is not advisable in between the toes, but around beneath the foot is very, very important. Then trimming of the nails. You have to trim it weekly if you can reach them. And it shouldn't be below some people trim it hard and it will go deep and below the edge. So when you are trimming, you have to trim across streets, and it shouldn't be curved inside to cause more harm to your foot. Then you can also use a file edger or a file board. We have files that you can also use to trim your nails. You protect the foot from hot or cold by avoiding contact with hot water surface and wearing socks to keep them warm. Most of the time, if you are in the house or if you are going to a place, you can wear your socks. Elevate your feet when you see that there are swellings, and when you set to, you can also decide to elevate it, and you should avoid crossing the legs. Sometimes when you cross the legs, what happens is you constrict some of the blood vessels, and it can easily bring about the numbness and tingling sensation we are preventing. And then you stop smoking. You know, smoking also has its own adverse effect on the blood vessels, which can also predispose the neuropathy and bringing about your foot problems. The wearing the socks, never walk barefoot. This has been the old way of educating walking of barefoot, wearing comfortable shoes, feel inside of your shoes before putting them on. The feeling here is some of the shoes, sometimes they might be sharp object inside the shoes or blade or something. And if you don't check and then you just slip your leg inside your shoe, you can easily get a cut or being hurt, and that can also bring another problem. And then with the barefooted, I remember most of my participants said they never walked barefooted. All they realized was the blister formation. So now I can't generalize my findings because it was a qualitative study and the study population was very few. So that findings cannot be generalized. I hope with time, when there is a repetition of such study and across the country, we might check to see if indeed other patients are having similar occurrences, or other patients are having similar um, um, experiences. When to see a podiatrist, I talked about the podiatrist. Of course, we don't have them here in Ghana. That's a sad issue. Those I don't know, do you have people in Accra? Our students here, do you have anybody with us who stays in Accra or the Tadi, those who are working in Tadi, Cape Coast? Do you have podiatrist nurses around? If you are not sure, please do check for us. Let's see if we have some in the country. Okay, I'm sure some of you are working at various facilities whilst the house. And when to see a podiatrist, these podiatrists are specialist nurses who check the foot. Their special is just foot care. And once this patient has been confirmed of diabetes and is also having any neuropathic symptoms, the podiatrist is supposed to be seen. Once, when one see well enough to cut, when one cannot see well enough to cut his own nails, You can see the projections for help. The toenails too are too thick for you to cut. That one too, you can go and see them. If you have thick callus, callus are hardened skin portion, maybe around the foot. You know, especially the Muslims. I remember one Muslim participant that I interviewed. She mentioned that there was a callus formation, you know, when we do the sitting whilst we pray. And so parts of our foot around the foot becomes hardened. That's the callus formation. You might not be a Muslim, but you can also have callus formation. So you can look at images of calluses and see how it is being formed. And if you are having one, you please check the projections. If you have never had any foot ulcer before, you can also check. And if you have numbness in your feet, that's another indication to also see the projections for self-check. So treatment, diabetes, the insulin, and then the treatment that we put our patients on. We have the oral medications and we have insulin. The oral medications, we have the sulfonylureas, and under these tell the pancreas to make more insulin. The sulfonylureas. These are categories of anti-diabetic medication, and their indications is to tell the pancreas to produce more insulin for the body. So example of those medications, we have the metformin. And the metformin, what it does is that it tells the liver to stop sending out sugar. You know, the liver has the capacity of converting either protein or other forms of food product to sugars. So this metformin, what it does is that it acts directly on the liver to stop producing more sugar in the blood. It can also help people to lose some weight. The metformin has weight losing capacity. So once you are on metformin, it also helps you to reduce weight. And the main side effects are upset, stomach upset, and diarrhea. So these are the medications that patients are being put on. So with regards to insulin, these are example of the insulin injections, then the insulin medications, and then this is just a glucometer, the glucose strip, and then it's used to check before you administer insulin, there is a total need, or it's very, very important to make sure you check your glucose level before you give the insulin. When you check your glucose level and the glucose level is already low, don't administer even if it is time. Some nurses are behaving like robots. You know, robots, when you set it to do something and it is time, whether it is good or bad, they will make sure they do it. That is how robots operate. But humans are not robots, and nurses are not robots. So once you are a nurse, if the physician has administered, prescribe insulin, maybe 5 units or 100 units BD. Before you administer the insulin, the first thing you need to do is to check the sugar level. If you check the sugar level and maybe it's fasting blood sugar, the fasting blood sugar is not supposed to be more than 7 millimole per liter. Now you check the sugar level and the fasting blood sugar is around 5 millimole per liter. Already it is low. So what is informing you, the nurse, to still give the insulin to make this patient go hypoglycemic and die off because we think it has been prescribed by the doctor? So I would want to sensitize nurses that we are not robots. We use our conscience to work. Even though the physician, who is the doctor, has prescribed, it is mandatory that you, the nurse, must check the glucose level before you administer the insulin. And so if you check and the glucose level is so low, you don't have to administer the insulin right in the nurse's nose. When glucose was checked, it was this, so the insulin was not administered. Then you now monitor, allow your patient to eat at the right time. You monitor your patient and make sure there's a need for you to give the insulin before you give. Now, use in patient with the insulin is used in patient with, most of the time is type 1, but in some cases type 2. This used to replace the insulin your body is no longer able to make. And you need insulin to move this glucose into the cells after eating. And this lowers the blood sugar and provides fuel for your body. So we are saying this is just the indication for the insulin. Once the insulin is being administered, it helps the cells to what? Reuptake the sugar level, hence bringing the sugar level low. Available in different formulation, we have the short-acting insulin, the long-acting insulin, and the insulin mixers. Types of insulin. We have the meal insulin, the long-acting, the insulin mixers, and then it comes in vials or pens. These are varieties of the insulin. You know, vials, here is a vial, this is called a vial, and this is called a pen. It's recently that I saw some facility having it, the pen one. You know, it's already graduated and the amount is already in it. And so you withdraw. This is the tip of it. You use it to withdraw and then you give it, you administer it into your patient's system. How one needs to administer insulin. I think this will be taken care of with advanced nursing, administering of insulin injection, and how it's supposed to be done. Have you done diabetes in advanced nursing?
Not yet.
Not yet. So it will be taken care of how to administer insulin. That is for another course. So we'll end here. We will not tackle this one because it's for a different course. Then how to store it. It's being stored in the fridge. You don't have to, and also make sure you check the expiry dates before you administer. Very, very important. Then physical activity or exercise is another way of checking or monitoring the sugar level. One needs to work for cure, for the lab of cure. So those who don't like walking, make sure you make walking a hobby. After eating a heavy meal, walk around, burn the calories, and then you'll be good to go. So physical activity or exercise improves cholesterol and other lipids. If the person is hypertensive, it controls the blood pressure. It also improves cardiovascular function. A diminished potential for weight gain. To exercise, these are just the essence of exercise, physical activity. When you start up your exercise program, be sure it is enjoyable. So if you are the type who doesn't like walking, but you like riding bicycle, you make it a hobby and ride bicycle every day. If you're the type who doesn't like riding bicycle and you like running, you make running, jogging, a form of exercise, something that you enjoy doing. Some people also like swimming, you know. All these are forms of exercise. If you love swimming, make it a routine and swim to burn down your calorie if you are being diagnosed of exercise. So we are saying that the exercise that one decides to choose should be something that he really enjoys most and should make it a routine and do it at least 5 to 10 minutes, 3 to every 4 days. And when you are ready, it should be gradually increase the length of time you exercise and the number of days you exercise in each week, which is also very, very important. We have types of exercise. We have the aerobic ones and anaerobic ones. I'll not take you through all that. And so we have the aerobic one is when you use more of oxygen, and so you walk, you ride, you swim, and that one improves the heart fitness. The anaerobic exercises, the one that doesn't use, you don't have to use enough oxygen, and lasts for short duration, and that one improves muscle strength. So what we really need here is the aerobic ones, not the anaerobic ones. Now, exercise recommendation for diabetes The aerobic ones, you can do it at least 150 minutes per week in moderate, or 90 minutes per week, the vigorous one. Then you spread it over at least 3 days, no skipping more than 2 days in a row. So these are just some recommendations for the exercise. And what this exercise does is what? It controls, it helps control the sugar level in your system. That's all it is doing. Okay. The physical activity, the caution, precaution, avoid exercise in extreme heat or cold. And then when maintaining adequate hydration before, during, and after. Whilst doing the exercise, make sure you have enough water around you, and then maintain adequate hydration. Then you self-monitor your glucose level. Please don't forget that's very, very important in all the if anything, the treatment modalities. We have three main treatment modalities. We have the diet, we have the exercise, we have the monitoring, and we have the medication. These are the four main treatment modalities: exercise, diet, monitoring, and medication. And so we are saying that with monitoring, it has to run through all to the end. If you are exercising, if you are dieting, if you are doing medication, monitoring of the sugar level shouldn't be ruled out. So it has to be, that one runs throughout all the treatment modalities. Very, very essential. And when you are exercising, your risk for hypoglycemia may be greater. And so make sure you don't do exotic exercise. Exercise within your capacity, you let it be. Now, food and the glucose. Food and glucose, that carbo, if you have carbo of high 100%, the protein can be 50% and the fats should be 10%. This is just an analogy, okay? And usually the diet is usually being prescribed by the dietitian. So you realize that in most facility, people who are having diabetes, what they do is that after you've been taken care of, after you've been shown how to take your insulin, you've been asked to do your exercise, when it's reached the diet level, we refer you to the dietitian, especially for the bigger facility. I don't know of the smaller facilities. For the smaller facilities, I think the nurse might end up using her own discretion to give education on your diet. Because back in Continent, when I was working at the district facility, we didn't have any dietitian there. And so most of the work was done by the nurses. So the most important objective in the dietary management of diabetes is to control the sugar level. That is in all the treatment modality. The cardinal principle is what? To control the sugar level. And once your food is being taken, you make sure you also monitor your glucose level to make sure you are not going overboard. Okay. And then there are times we advise that in between meals, like if you have a bowl, whatever amount you use to eat, you divide it by half, then you compensate it with a stew or soup so that you have adequate soup to make you feel full, or adequate stew to make you feel full. That has been the new trend in education for diet. A meal plan for diabetes focuses on the percentage of calorie that comes from the carbo, proteins, and fat. It is recommended that the carbohydrates should be higher than fat and protein. Of every calorie intake, of 50% to 60 should be derived from the carbohydrates. So we have people who advise diabetes not to eat plantain. It also saying not eat cassava but eat plantain. It's been on record that plantain has high calorie than cassava. So please, if you are the type of nurse educating your patient to stop eating cassava but eat plantain, check your education right. They can eat everything in this world, but they should remember that the amount should be reduced and it should be compensated with the protein, the fats, or the vegetables that they are eating to make them full. 20% to 30% from fats, 10% all this percentage is not necessary here. Carbohydrate food have the greatest effect on the blood sugar level because they are more quickly digested than other foods and converted to glucose rapidly. The majority of selection for carbo should come from the whole grain. A whole grain with wheat, like the wheat, it should have cereals, whole grain. Example, the maize, the wheat, and all that. We recommend those kind of carbohydrates. So that is that. The fats, that is that for that. The fiber food is also very essential. Make sure you encourage your patient to take a more fiber diet, which is also very, very important. And what the fiber diet that is, it improves blood glucose level and it decreases the need for the amount of glucose in the blood. The fiber increases satiety, which is helpful for weight loss. So once you take in more fiber, you feel full, okay? And that will make you reduce the amount of carbo, which will make you grow fat. So that's the essence of the fiber diet. And then the protein is the same. So here the dietitians are in charge. And I mentioned that in treatment of diabetes, we have four main. We have the medications, we have the monitoring, that's two. We have exercise, three, and we have diet management, four. So the diet management, what you should remember is that you should have the balanced meal, but the carbohydrates should be more than the protein and then the fats. And then the amount that is supposed to be eaten should be calculated with the dietitian. And the essence of the food that is being taken should also help in regulating the amount of glucose in the blood. And again, we should remember that eating fiber foods is very, very essential because it improves satiety. It makes the person feel satisfied. And in so doing, there is less amount of carbo that will be taken. Hence, if the person is taking less carbohydrate, it means that uh, it should now it will help control the sugar level by reducing the weight. So that's the essence of the high fiber diet. The eating of fruits instead of drinking juices decreases another because the fiber in the fruit slows absorption. And so it's better to eat whole fruit instead of buying juice from the shops. So if you have a grandmother or a mother with diabetic patient, don't be buying the fruit from the shop, the mall, and all those places, but rather go and buy whole fruits. And most of whole fruits are having lots of fiber diets. And these fiber diets help the person feel satisfied, hence reduce the amount of carbohydrate that the person does take. So at this juncture, we would have to end with diabetes mellitus. Let me see if there is something new that I didn't bring on board from this. If it's the same, I'll just give the slides out to read. It's virtually the same. All right, so we'll end here. Any question, Joycelyn? We'll end here with diabetes. We'll look at other conditions and then we'll end the class. Joycelyn, seeing your hands up. Any question?
Good morning.
Yeah, good morning.
Yeah, sister, you said that the metformin, when they take it, it helps them to reduce weight. Does it mean if someone wants to take it to reduce his or her weight, can the person go and buy it from the shop, drugstore, without a
No,
prescription of?
no, please. It's not meant, the essence of metformin is not meant for obese patients, but it's meant for
All
diabetic
right.
patients who are obese
Okay.
because it's anti-diabetic drug, and what it does is that it reduces the glucose level in your system. And so if someone is obese and it has not been diagnosed of diabetes, and the person goes in to buy the metformin, do you know what will happen to the patient? Just guess what will happen to this person. Apart from the weight that the patient will lose, what will be the other thing that might happen to this patient?
It will reduce the person's glucose level.
And then what will happen?
It can lead to other heart diseases, stroke.
It's not
No, if someone's glucose level is low, it doesn't go to the heart disease. So if someone's glucose level is low, what happens? When there's low blood glucose level, what happens is that the person can go into comatose states.
yes.
Will be in a
Yes.
comatose state and the person might die.
Madam.
Nti yɛsrɛ mo, yɛnka
Yes.
say it's meant for any ordinary person, okay?
All right.
Mm-hmm.
Thank you.
You're welcome.
Sister,
Yes.
please, is diabetes only associated with the foot or the leg? Because you kept stressing on the foot and the leg, leaving other parts like the
Like the
arm
arm.
or the
Arm no, nokorɛ ɛwɔ hɔ ne sɛ, it's not just the foot, but the truth is that if you take 100 diabetics, those who have foot foot neuropathy, the upper limb retinopathy, which is the hand, is like 1 in 100. And then the arm is always active, it's doing a lot of activities. So it's very hard for the arm to experience that retinopathy. All the same, if you are diabetic and you have any numbness or tingling sensation in the arm, you shouldn't hesitate to report for the necessary intervention to be taking place to correct any anomaly, because it does affect both. That's the foot and then the arm. But the reason why I was stressing on the foot is that it is more of there's a high probability that the foot will be affected than the arm. That's the only, that's why usually when we are giving education, and even if you go to the hospital facility, they also stress more on the foot than the arm. But that does not rule out the fact that the arm is equally what affected. Is that okay?
yes, sister.
Another
Sister, good morning. Sister, good morning.
good morning.
Please, I didn't join early because I'm having some fault with my phone, but I have a question.
Okay, it's welcome.
Okay. Sister, my question is with the diabetic. I learned with the diabetic,
Okay,
they are having special sugar that they should take.
okay.
But in crisis, why do they take the raw sugar, but not rather their sugar?
Yeah, in crisis, their sugar doesn't bring about increasing in the high sugar level. In crisis mean when the patient is having a hypoglycemia. That is the crisis you are talking about. When the person is
Yes.
having low sugar level, that is a hypoglycemia. Let me share this slide. It's very, very important for me to continue what I'm explaining with you. So let me do a new share. Have I had a new share? Has it shown?
No, please.
Okay. So I will share with you that slide. Not everything on that slide is very essential, but there are two important points here that needs to be shared. And that is why, based on the question that has been asked, the signs and symptoms of hypoglycemia is very, very important. So that when you are giving education to your patients on the signs and symptoms of hypoglycemia, which is also another crisis, it's a acute complication. It happens suddenly, and once it happens suddenly, what happens is that if care is not taken, the patient will die. You know, the patient goes into coma and he dies. And so I think that information cannot be taken for granted. We'll have to share that with you right away. Have you had a new share?
No.
Hey. Yeah, not much.
You've not closed the previous slide.
Yeah, I'm coming. Yeah, is a new shed. Is it shown?
Yes.
So hypoglycemia. This is what I intend showing the signs and symptoms of hypoglycemia. With the hyperglycemia, there are times you don't even see the signs when the sugar level is going high. It can go as high, but hypo, once you go below, hypoglycemia is the term that is given to the sugar level less than 2.2 millimole per liter. 2.2 millimole per liter. And these are the clinical manifestations. You realize that this individual will start having tremors. Ne ho wo so, ayɛ sɛ obi si nketenkete akyɛ me. Na ne ho wo so, ne ho yɛ ne basa 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 basa, you know. And then once this person is having tremors of the body, the arms, the legs, and is sweating, if you are in the ward, if you are sitting at the OPD, and all of a sudden you realize that a patient is sitting down and sweating all of a sudden profusely, stop whatever you are doing and attend to that patient, because if you are not careful, the patient will just go off within some few minutes, and there will be tachycardia, very fast heart beats, you know, and then or pulse beats. And then severe hypoglycemia can also result in fits. The person falls, and you think that if the person is having epilepsy. No, not all form of fits is a sign of epileptic attack. It's also that's the severe form. The person can fall and go into epileptic fits, and then comatose states. The person goes into the comatose states, and if fast intervention is not taken, this patient can die. And this, if death does not occur, there can also be permanent brain damage. And I've always been saying that if this individual who is having permanent brain damage, it's better the person even dies off, because virtually if the brain has been damaged permanently, the person becomes like a vegetable. That's the term we give to those kind of patients. We call them vegetable. What the whole no, he's no more a human being. He's more of a vegetable. Like why redundant? You can't use this individual for virtually anything, you know. So we are saying that when you have this cardinal, that's the question the lady is asking. Why is it that our patient or our diabetic patient, their natural sugars that we give when we are monitoring their sugar level, when they go into this hypoglycemia, which is another crisis of its own, we rather prefer the proper sugar, that's the white sugar, instead of their own sugars that we give? The reason is that this proper sugar or the white sugars that we eat, when you absorb it directly, when you put it in the water and you take it into your system, it's just the normal glucose. So it's correct. It now corrects the hypoglycemia. So we always educate our patient that if you are monitoring or if you see these symptoms, or if you have the glucometer and you are monitoring and you realize that it's going below 2.2, quickly take just a half spoon into a glass of water and drink it quick. Or buy normal Fanta or Coke. You know this Fanta or Coke is on sugar song that they have used, so it's nothing. And they've added some things to it. Or normal Coke bottle, the 500 ml or is it 600 ml, half, then you drink it. Once you drink it, quickly it just absorbs into it goes directly into your bloodstream and then now corrects the hypoglycemia. So it's a form of like a quick intervention to correct the glucose level, especially when it is very, very low. And then with regards to the hyperglycemia, let me see if with that one, that is what we have been managing all this while. So that is the intervention that really needs a quick one. Have I really answered your question? The lady who asked.
Yes, please.
All right. Any other question, please? I might give you this. This is will be of use for other. You can just read it if you have. This was what I was talking about. Those who are having gestational diabetes, they have macrosomic babies whose weights are above 4.5. So if you're a mother and your babies are so huge, around 4.5, don't be happy. Hey, me, I give birth to big babies, so a problem now. Check yourself, get proper resolutions, and then so that you don't give birth to such big babies. And these big babies, when they come and you don't monitor them, they easily die. They overweight. You have to check their sugar level, make sure you are feeding them and all that. If you don't give them proper attention, they can easily die. So you are midwives. That is why I'm bringing these points to your table. If you are mothering or if you are caring for a mother who is diabetic, make sure the baby when it's brought forth is under 24-hour monitoring check before you even let the person go home. And then the baby usually here is they say the hypoglycemia, hyperplasia of the fetal pancreatic beta cells. There's also excessive production of insulin up to 24 hours after delivery. And then if feeding is delayed, hypoglycemia will occur. And when hypoglycemia occur, we now know the consequences. You should correct it. If you don't correct it, this person or this baby won't pass off. And then polycythemia in response to the hyperinsulinemia. Jaundice too may also occur, and then the baby can also go through respiratory distress. So these are complications of these macrosomic babies. The baby can go into respiratory distress, and there will be also hyperinsulinemia in the baby. So regards to that, I mean, these are some few things that you should appreciate for macrosomic babies. Tucker raised the hand. Tucker, the floor is open. You can speak.
Mr. Good morning.
Good morning.
Mr. Please, is it true that pregnancy induces diabetic?
Mm-hmm.
I wanted to know, because some of the pregnant women, they will be diabetic. And you hear the doctor saying, after the delivery, it is because of the pregnancy, that's why the diabetes came about. So after the delivery, the diabetic will be off.
Yeah.
To be resolved. And why?
That's why I was explaining that. The reason before someone who is pregnant may be having diabetes, you have to start looking. You are working with the diabetics, right? So I will give you a task to do, and then you give us feedback later. When you are interacting with those women, you realize that either they have a family history of diabetes. That is one of it, most of the times.
Sister, I'm no more.
You are no more there.
Yes, please.
Don't worry. But that is, if you have the opportunity, I'm sure you have opportunity to be at the clinical side again. You can write this assignment down, use that as your check to understand certain things. There are things I've always been saying that what nurses fail to do is to do background checks, to do survey, to do research. Once they find a cell at the clinical site, all they care is about caring for them, giving them medication, vital signs, and they are done. You to sit down and do some few analysis, reflection. I've been saying there are things that we have missed so much that if we had known when whilst we were in the clinical field, we would have implemented. Try and do a survey about certain trends in our care. These things that we do. Why is it that patients having a if this person is pregnant, let me do some few questions and see. So you find out the family history. If the family history is paramount, you can now confirm that most people who are having gestational diabetes have family traits of diabetes. That one we can come out with the findings and even generalize as Africans. But currently, there hasn't been any reason why some women, when they get pregnant, their sugar level go up. But what they can associate with it is that it's due to the hormonal affecting the organs in your system. The same way some people get pregnant and their BP rises. And when the BP rises, we call it pregnancy-induced hypertension. The same way if someone is having blood pressure and is having pregnancy and his sugar level rises, we call it pregnancy-induced diabetes. Meaning that without the pregnancy, that person has never been diagnosed of what? Diabetes. So once there is pregnancy and now the sugar level is high, it is automatically confirmed that it is the pregnancy that has induced or that has bring or resurfaced or has brought up the condition. Hence, we now associate the condition to the pregnancy. But there hasn't been any confirmation why some women get that. But it has been confirmed that most of these women, once they get pregnant and it's being confirmed that they have diabetes, later in their life, that one someone did a study and it has now been generalized. Later in their life, so someone did that study is called a progressive study. You would collect all pregnant women who are having diabetes during pregnancy, wait and follow them out for maybe 5 to 10 years and see what is their state of condition. So based on this study that has been done for so many years, it has now been confirmed that once you have gestational diabetes, after 5 to 10 years of your life, there's a high probability that you will still have diabetes at your later stage in life. So that is all about these findings. There are things that sometimes medicine cannot explain. Until we do research, until we do our own findings, we cannot substantiate our point why things are happening. Just like as I'm speaking to you, we don't even know what causes cancer, but we can talk about predisposing factors of cancer. We have some diabetes. People cannot explain why. We have few ones that we can explain. For the type 1, we can explain why. Type 2, we know predisposing factors. We don't know the exact cause of it. So that is that for that explanation. Has the explanation gone down well, Talker? Hello?
Hi, sister.
Is the explanation clear?
Yes.
Okay. Any other question, please? It's a chat here. Let me see what is there. Is diabetes? Oh, okay. Dina has sent it. I think I've answered that question. Okay.
Sister,
Yes.
please, most people couldn't join today's class. Can you please drop the recorded version so that they can benefit
Okay.
aside the slides?
Okay. I'll see how best. I'm trying to get someone help me get most of the recorded version of our presentation to either a YouTube page or the school page. I don't know which of them. The school page sometimes is so difficult. What you have to do, you have to be dividing the slides into pieces before you can upload. The school page app takes, I think, just 70 megabytes. And by the end of this, we'll be getting about 1,000 something. And dividing this into bits and pieces is going to give me a very huge task. So what I would want to be doing is I would create a YouTube channel, drop the videos in, then I will share those channel, those link to the WhatsApp platform so that those who would wish to follow will just follow it through the YouTube channel. That one is easy to go there, join the link and watch it. But if I should pick it to that class page, sometimes the task or the help, what I go through is just unbearable. Yes. So thanks for that. We'll look at that. Okay. Any other question?
So, sister, please, the slides.
Yeah, the slides will surely be shared.
Hello, sister.
Yeah.
On the school page or on WhatsApp?
Any of them. It can be on WhatsApp, it can be on the school page. Depending on
Okay, sister.
So you check both concurrently.
Because I'm sure some of our colleagues too, they are not getting the access to the school page.
And because they have not paid, so how would they do end of semester?
Because of the fees.
That one day, maybe I will check which of them will be readily available then. Because my WhatsApp is not all the time that.
Sister, and please, we have a lot of slides too. You said you would be sending them, but you never sent them.
Hey, I never sent them, Mommy.
Okay.
Are you sure? I've sent some. I've sent so many.
Yes.
I've sent so many.
Hey, sister.
It's left with yours. So you like, if you wish, you put all your presentation in the class. Tell them to put, all of them to put your.
Sister, another presentation. Oh. The last time, was it cancer?
The cancer. Okay. Apart from cancer, what else haven't I given? I think that's the only thing I've not given.
Oh, so.
It's cancer. Yeah, we've done oncology. It's cancer we have done, but that one I'm sure that's the only one I haven't given out. That's what I can remember so far. For the rest, I'm sure I've given most of them out. Any other question? Contributions and all that? If not, we'll see if we should add one topic to it, and then we'll probably close for the day. I want
sister, please, about the midterm. When are we discussing it?
Let's do it on Monday. I think that will be better. Since most of you are not still on the platform. Or you wish we do it today, it's recorded, that would be okay. Should we do it today or Monday? The class should decide. Because today we are
okay.
Which of them do you prefer? I said, which of the days do you?
Please, I didn't hear.
I'm asking, which of the days do you prefer? Today or Monday?
Monday is okay.
All right. I'm trying to see if under the endocrine, I think we need to do another condition under the endocrine so that we'll finish endocrinology, endocrine system. And then I'm sure medicine we are almost done with. Rheumatoid arthritis. A musculoskeletal. We haven't done musculoskeletal system. We have a lot to go. We'll look at that briefly.
Please, is this under surgery or medical?
Surgery and medicine, they are virtually the same. The only difference is what I told you last time.
Okay.
Okay. So you look at those. If I'm treating diabetes, Diabetes, we don't do any surgical intervention in diabetes. The only time that diabetes become a surgical is when we are doing something like the person is having foot ulcer and we are going to do surgery,
Okay.
amputation. That's where the surgical intervention. Then you have to prepare the person, pre op, post op, and then. But anything regarding diabetes is virtually the same. And so when I'm bringing questions on the diabetes, it can be replicated in surgery as well. But the only difference is the management. Okay, the management and then the the activities that one needs to do. So that's it. Yeah, I'm looking
Yeah.
okay. Yeah, so let me see.
But
Yeah, I'm
a
listening.
diabetic patient who gets wounded,
Uh-huh.
the wound is not going to be healed. So does that mean
Eh, it,
our
uh-huh.
our priority is to manage the wound from being infected, like becoming infectious, like
Hey, the word the wound is not going to be healed shouldn't be your priority as a nurse or a midwife. The wound which can heal. But how the wound will
okay,
heal is what is paramount or is what we should be looking at. The question is,
okay,
how would the wound be healed?
okay,
The how is one, monitoring the sugar level. That's why I told you that in all the treatment modalities for diabetes, being it the education, being it the monitoring, being it the exercise, being it the medication, and all that. Monitoring is very cardinal and essential in all these treatment modalities. So meaning that if someone has developed diabetic foot ulcer, among the healing process, the number one reason how the wound will be healed is making sure the glucose level is maintained. I remember I had a situation, I had a confrontation with a diabetic patient who was being admitted at the surgical ward. And then the surgical nurses were complaining that it's the medical team that needs to take care of the monitoring of the sugar level. And I was questioning the nurse. I questioned her that you are here managing the wound. You think the wound is your priority. But have you forgotten that the wound that you claim is your priority, which is dressing it aseptically, if you do not check the sugar level and make sure the sugar level is within the normal range, your wound will never heal. Then what work are you doing? So if you find yourself at the surgical unit and you are managing a diabetic patient with a wound, your number one priority is to make sure you maintain the sugar level. Make sure the sugar level is within the normal range. Otherwise, no matter how much aseptic technique you put in place in managing this wound, you will surely not achieve your results. At the end of the day, your result is to help the wound to heal. And we are telling you that as specialists in diabetes or as people who are so passionate about diabetes, we are telling you that if you are managing someone with diabetes with a wound, make sure as you are dressing your wound aseptically, you are also helping your patient to maintain a normal glucose level. Otherwise, no matter what you do, your wound will never be healed. And it has been confirmed through the study I did that this patient realized that anytime their sugar level was going high, the wound was deteriorating, was becoming worse. It was becoming pungent, it was becoming smelly. It was like you can think of anything that makes wound bad. So I'm entreating that those who will also be taking care of patients with diabetes, always encourage your patient to put in place activities that will reduce the sugar level. Among them is the diet, among them is the exercise, among them is the oral medication, and also you dressing your wound aseptically. So if you don't do all these three or all these four concurrently, your aseptic dressing will not help the wound to heal. So those who are able to control their sugar level, their wound heal. Are you following the discussion? All
yes, please.
diabetics who are able to maintain a very good sugar level, when they develop the wound heal. all those who do not maintain proper sugar level, those are the people that won't delay. There's always delay in wound healing. So that is the correspondence here.
Okay.
Mhm.
Thank you.
You're welcome. There is, I think we will do the thyroiditis, which is the second endocrine system, endocrine condition that we need to finish up with the endocrine system. Then finally, we'll look at the musculoskeletal, and then we'll be done with. I'm sure that those are the few ones that we really need to look at. Hypopituitarism. Okay. Okay, before someone will get thyroiditis, let me share this slide. We have to look at that. Please, can you see the shared screen?
Yes, please.
Yes, sister.
Okay. Under the, I will quickly take you through. That one is really not essential, but if you have a bit of a knowledge, it's going to be a great help regarding what we intend doing right now. That is hypopituitarism. We just quickly look at that and then we'll continue. When we say hypopituitarism, is just a pituitary insufficiency resulting from destruction of the anterior lobe of the pituitary gland. Once the pituitary gland does produce the pituitary in our system. And so we are saying that hypopituitarism is just a pituitary insufficiency. That's pituitary that is being produced in our system. If it is insufficient, then that is what we term as the hypopituitarism. And in this condition, the amount of can you please mute your microphone? On your turn again. Yeah, send me it. So this is all about, so at least you have a few information of the pituitary gland. It does produce the pituitary in the system. And once it is insufficient in the system, that is what we call the hypopituitarism. So we'll not look at the incident and all that. I just wanted you to have a view. Let's look at the just wanted you to look at the clinical manifestation. The clinical manifestation of the hypopituitarism. We have deficiency of the gonadotropins. The gonadotropins is related to the male sex hormone, which has both, we have the follicle stimulating hormone and luteinizing hormone. The gonadotropin does produce or help us to get the follicle stimulating hormone and the luteinizing hormones in our system. And once there's deficiency of these luteinizing hormone, it's more common that these individual hormones would help. There will be low, the person will have amenorrhea, and then there's also high probability that this individual will be infertile for females. And for males, what happens is that there will be loss of facial or scrotal hair or the trunk hair. So these kind of men usually do not have facial hair, they do have scrotal hair, they do also have trunk hair. It can also be there, but it might be reduced. And there's also a high probability that this individual will have a muscle mass decreased, and they have also testicular softening. Their testicles will be softened. So the gonadotropin, the patients who are having low pituitarism usually have deficiency in these gonadotropins. And these gonadotropins are made of two main hormones, and these hormones are called the follicle stimulating hormones and the luteinizing hormone. Once these individuals, being it male or female, are lacking these gonadotropins, what happens is that in females, they may be infertile, and they might also they will also be absent of menses, that is amenorrhea, or oligorrhea, which is few menstrual flow or little menstrual flow. And in men, these are the testicle softening, the muscle mass, decrease in their muscle mass, and again, the facial or scrotal or trunk hair will be not present. In both sexes, there's decreased libido. You know, some women will tell you, from childhood to adulthood to old age, the person doesn't know what libido is all about. No sex drive, nothing. Loss of sexual function. Others also don't have the urge for sex. In male, maybe there will be no anal erections and all that. In female, the drive is simply not there, no sexual satisfaction and all that. There's also increase in risk of osteoporosis, that the bone becomes fragile, hence they easily get fracture. There's also higher tendency of growth retardation, and then short stature. They're also usually small in size or short in height. Deficiency of these growth hormone more common in people with underlying tumor, central obesity, and all that. So this is just the highlight of these hormonal. They are all parts of the endocrine disease conditions. And another deficiency is the adrenocorticotropic hormone. Usually, when these people lack the glucocorticoids, such as the cortisol by the adrenal gland. So this adrenal gland has series of hormones that it does release, the gonadotropins, the adrenocorticotropics, and all that. All these are hormones that the adrenal gland releases. And if there is deficiency in this, the glucocorticoids, an example of the glucocorticoids are the cortisol. There is fatigue, there's weight loss, failure to thrive, especially in children, they don't grow. Delayed puberty, a child who have reached adolescence, maybe a female around 15, but the chest is flat, the buttock is flat, you don't see any adolescent developmentals in that child and all that. It's a form of deficiency in these glucocorticoids, and you can also go to the hospital for them to check if there will be any remedy for them. There's sometimes shock, there's vomiting, there is anemia. Now we move to what we intend doing for today. And then when someone is having deficiency in thyroid stimulating hormone, the thyroid gland, it stimulates or it produces thyroid stimulating hormone. And once there is deficiency, when there is low production of these thyroid stimulating hormone in your system, the person will lack the production of thyroxine two main hormones are working here. For hypothyroidism to occur, one will be lacking either thyroxine or the triiodothyronine in the thyroid gland. So these are the two main hormones that are being produced by the thyroid gland. And these thyroid stimulating hormones are the thyroxine and the triiodothyronine. So this is what we intend doing for today. If someone is having or lacking these hormones, that's the thyroxine and the triiodothyronine, what happens is that the person have series of tiredness. The person easily gets tired, easily fatigue, weakness, intolerance to cold. When there is cold weather, this person is unable to contain it. He sees cold weather or cold as a very serious issue. There's also constipation. A person has serious constipation. We all know what constipation is. There is weight gain, there is hair loss, a slow heart rate, and a low blood pressure. So if you have all these cardinal signs and symptoms, you can check your thyroid system. You go take your blood sample to check if your thyroid gland is, or your thyroid hormones is producing enough thyronine or triiodothyronine in your system. Now, if you have deficiency in the prolactin, and that woman may be having decreased production of the milk or absence of growth of pubic and axillary hair. So the prolactin is for both production of milk as well as the pubic hair or the axillary hair. And so these are just some few. And then when someone is deficiency in the diuretic hormone can cause diabetes insipidus. And then deficiency in oxytocin leads to decreased uterine contraction during labor. And then diagnostic investigation, no go there. I want to quickly move to what we intend doing for the day, for you to appreciate the endocrine system, what it's really all about, and then what we do. So now let's look at thyroiditis. This is what I intend we looking at. Thyroiditis is simply a primary characterized by an inflammation, enlargement, and dysfunction of the thyroid gland. We have types of it. We have the chronic thyroiditis, which is called Hashimoto's thyroiditis, the chronic one. It takes a very longer period. We have the subacute thyroiditis, which is called the Quevins thyroiditis. We have the acute one, and we have the silent thyroiditis. Okay. Causes. It is caused by bacteria Staphylococcus aureus or Mycobacterium fungal infection. The incidence has sudden onsets and is common among the Europeans. The signs and symptoms. There is anterior neck pain, swelling, fever, dysphagia, dysphonia, and there may be pharyngitis or pharyngeal pain. There may be warmth, erythema, and tenderness of the thyroid gland. Dysphagia, we've talked about it, difficulty in swallowing. Dysphonia, difficulty in speaking. So these are the two difference. With the chronic thyroiditis, is more commonly associated with an autoimmune process in which the body produces antibody in defensive response to perceive the thyroid tissue as antigen. So any disease condition that you see autoimmune response, it means that at that point, the body's own antibodies are fighting against its own tissue as what? antigens. They see it as foreign body and they end up fighting against it. This is marked lymphocytic infiltration of the thyroid tissue and is also called the Hashimoto's thyroiditis. Goiter is an example feature of this disease and involves the entire gland. Typically, the thyroid feels soft and rubbery or palpable. Palpation and enlargement may not always be symmetrical. So there are times that you observe when you are observing, you are supposed to think that the enlargement is symmetrical, but we are saying that not all the time that the enlargement of the thyroid gland is symmetrical. It's not the same. Symmetrical means it's not, you can't see the swelling at the left side of the neck to be the same as that of the right. There are times that one is bigger than the other side. Despite this enlargement, no thyroid breach can be auscultated. As the disease progresses, the thyroid parenchyma is replaced more and more by lymphocytes and fibrous tissue. Symptoms of hypothyroidism becomes more apparent. The Hashimoto's thyroiditis is frequently found in conjunction with other autoimmune disorders, such as the pernicious anemia, the lupus erythematosus, rheumatoid arthritis, Addison's Graves disease, and others. Except for the sensation of the localized compression on the neck strictures, this disorder itself is usually asymptomatic. So you realize that when people are having the goiter, okay, which is also known as the chronic thyroiditis, what happens is that apart from the enlargement that you can see with your naked eye, the local compression, it presses on the neck structures. Apart from that, it doesn't have any other symptoms. As the thyroid tissue becomes progressively unfunctional, idiopathic myasthenia can occur. So we are saying that there are times that it becomes so that the individual is unable to function anyway due to this enlargement, and that's one that will need for medical attention. So you realize that some people will have it for a very long time before they even report. Either cosmetically they don't feel comfortable, that's why they are reporting, or they are having other incidents or other problems that they feel would need medical attention before they do reports. Its onset is insidious and affects women between the ages of 30 and 50. And we have the subacute thyroiditis. This is an inflammatory condition that causes painful enlargement of the thyroid gland. It frequently occurs several weeks after the viral infection, such as the UTI, the mumps, and the adenovirus infections. However, these mumps, I don't know when you know in and the urinary tract infection, the UTI is the urinary tract infection. The adenovirus is another type of virus that give viral infection. Now, we are saying that once the viral infection has been proven, subacute thyroiditis is rather benign disorder and is usually treated symptomatically with success. Incidence is an abrupt onset and is predominantly affect women between 40 and 50. There is enlargement and tenderness of the thyroid gland. You can see that it is there. It's really large. There is pain that might radiate to the ears. There can be fever. We talked about the mumps, the UTI, urinary tract infection. All these are viral bacterial that can bring about hence there is fever, there is malaise. The overlying skin is reddened and warm. Swallowing may be difficult and uncomfortable. The patient may feel irritable, nervous, insomnia, that's inability to sleep at night, and there can also be weight loss. The silent thyroiditis is a form of the lymphocytic thyroiditis, and with this one, it has a variable onset, and it may occur postpartum during the postpartum period. So postpartum means after delivery. those periods, sometimes you can get this silent thyroiditis. Diagnostic investigation for this thyroiditis. When you do nuclear scan, radioactive iodine uptake, which can tell if a person has grave disease or toxic multinodular goiter or thyroiditis. When you do nuclear scan or radioactive iodine uptake, this radioactive iodine uptake, the person swallows it, and then the scan is done. And then they will now use that scan to check whether the individual has grave disease or not. The second diagnostic finding is the CT scan, the computed tomography scan, can also help detect and diagnose if the thyroid, the larger thyroid nodules, if there's involvement of these larger thyroid nodules. Magnetic resonance imaging is also used to evaluate the size, the shape, as well as the thyroid involved. So then that one is more of an advanced scan diagnostic tool. And what it does is that it will give you the specific size, the shape, how it has affected the thyroid gland, and the type of the thyroid, which part of the thyroid is being involved. It will give you the specifics. Now we have thyroid ultrasound. It's also another form of scan, specifically to the thyroid, to evaluate the nodules, the lumps, and enlargement of the thyroid gland. And then this can help to detect whether a nodule is in a fluid-filled cyst or mass of solid tissues. Then a needle biopsy is also known as a fine needle aspiration, is used to help evaluate lumps or nodules. So you use a needle to take sample of the goiter around the neck. Then that would help you to check if or confirm whether this goiter has nodules or lumps. And we also have thyroid blood test. So you take blood sample, and that blood sample will rule out whether there will help you detect whether there is thyroiditis or not. Then thyroid stimulating tests and other series of tests, also thyroid total thyroxine, free thyroxine, and then thyroid stimulating immunoglobulins. All these are forms of blood tests, and when you do it, it will reveal whether you have thyroid stimulating, you have a total thyroxine in your blood, or you have free thyroxine in your blood, or you have thyroid stimulating immunoglobulin, which is the antibodies in your blood. All these are series of lab investigation, but the blood is used to do this test. The treatment with the acute antimicrobial agent or fluid replacement can be given. Subacute or acute form of salicylate NSAIDs are given because there is pain, there is inflammation. Hence, this one, the NSAIDs are very essential. If there is no response to these drugs in 48 hours, then we will give corticosteroids to correct it. In subacute, aspirin acetaminophen is also administered to relieve fever and discomfort. And in chronic thyroiditis, due to the chronic nature, thyroid gland is replaced by lymphocytes and fibrous tissue. So with this, it's the same thing, the nursing management to give the emotional supports. You should instruct, you should be instructed to remain under close health supervision so that progress can be monitored. We teach patients to be able to detect signs and symptoms of the disease caused by the autoimmune, which is also called the Graves' disease or the Addison's disease. You educate patients on the stress management technique against the autoimmune disease. Yes. Yes. Give the patient list of goitrogenous foods. Yes. Kachelina Sawamra. Teach the patient about the side effect of the thyroid hormone. Replace drugs and corticosteroids and measure to manage them. So this is that for the thyroid. Then we have the simple goiter, which we all know. Also have similar clinical manifestations and all that. And let's see if we can quickly go through to the end and end it for the day. Ana we-engage nkwalaa na wohwɛ nkwalaa no bahasa. Okay. So let's quickly look at the simple goiter. What needs to be appreciated, and then we'll look at hyperthyroidism, and then the simple goiter is the enlargement of the thyroid gland, usually visible as a swelling of the neck. It is a swelling in the neck or larynx. Goiter rarely occurs when the thyroid gland is functioning properly. So at the end of the day, the underlying cause of these thyroidism conditions is due to what? The improper functioning of these thyroid gland. Okay. So we are saying that worldwide, we have 90% cases of goiter that are being caused by iodine insufficiency or iodine deficiency. So once we have iodine deficiency, there's a high tendency that the thyroid and the swelling of the neck or larynx will be exposed or would show. And goiter associated with hypo is really associated with hypothyroidism and may present with symptoms often unspecific and hard to diagnose. Goiter is not associated with hormonal abnormalities and will not cause any symptoms apart from the pressure of the anterior neck mass. Simple goiter can be classified into two main categories. We have the sporadic goiter and the endemic goiter. The sporadic is isolated and scattered, whilst the endemic is more common in the area. The endemic is when the disease is prevalent or more common in the area. It is usually due to nutritional or iodine deficiency. The causes of simple goiter. We have dietary deficiency of the iodine, which is the main cardinal cause. We have the iodine absorption inhibitors in diet, excess calcium in diet. Once we have this excess calcium, it will prevent the absorption of iodine. So we call them iodine absorption inhibitors. Intake of goitrogenic foods such as soya bean, peanuts, strawberries, cabbage, groundnuts, broccoli, etc., prevent concentration of iodine by the thyroid gland. So if you are taking this goitrogenic food, such as these soya beans, it can also predispose you to the simple goiter because they do not help the intake of, or they do not help the thyroid gland to produce or help uptake of the iodine. Hereditary, it can also be a hereditary condition. Prolonged treatment with sulfonamides or goitrogenic drug. Example of goitrogenic drugs are iodine and the propyl urasols. And these patients with simple goiter may present the following symptoms. The thyroid gland is enlarged, which is visible around the neck. Obstructive symptom may occur. The word is may occur. Enlargement of neck veins. You know, once there is pressure on the blood vessels, the neck veins may be enlarged, causing the varicose veins around the neck. Breathlessness due to the compression of the structure on the windpipe. You can get difficulty in breathing as a result of the enlarged thyroid gland on the windpipe. There is also difficulty in swallowing due to the same enlarged thyroid gland on the digestive neck, the esophagus area. You know the neck, you have the esophagus there, which helps you take your food, it passes through the esophagus before it goes down to the rest of the digestive tract. You have the neck pain, not present in all patients. Not all patients experiences the neck pain. The pathophysiology, we are saying that the lack of iodine in the body inhibits or suppresses the synthesis and secretion of the thyroid hormone, that's the T3, T4. This alters the feedback system, resulting in continued secretion of the thyroid stimulating hormones. The gland is unnecessarily stimulated. Under this condition, it begins to enlarge in an attempt to increase its output to meet the body's need. This causes overproduction of the thyroglobulin precursors and thyroid gland hypertrophy. Let's see the diagnostic investigations, clinical manifestations, and complete physical examination suggest the condition. Ultrasound to find out the single nodule, radioactive iodine, chest X-ray, blood test, ultrasound scan, and all that are all diagnostic measures to confirm the simple goiter. The treatment is dependent on the size and cost. Treatment in adult requires administration of iodine preparation. An operation to remove some or all of the thyroid gland may be an option. Radioactive iodine treatment may also be an option. Treatment with simple goiter during childhood till puberty is also an adequate iodine diet for 1 to 2 years. And the multinodular simple goiter becomes unresponsive to the Xironin is operated. So partial thyroidectomy can be done to correct this anomaly. So the nursing management is the same thing. We give a psychological care. We know what goes into psychological care. Mariam, what goes into psychological care? Is she with us or she's off? Mariam,
Sister,
what goes into psychological care? Oh. Hey, Mariam, I'm waiting. I can't hear you.
Hello, sister.
I
Please,
asked.
I just joined again, but is a psychological of which one? Psychological care of
Hey, to this long time, where were you? You said you just joined. We are doing Goita.
yeah, it's
We
on
are,
and off.
we are doing simple Goita. So as for psychological care, it's the same throughout to the end. It's not different. So you add your voice to simple goiter is simply an enlargement of the thyroid gland, and the thyroid gland is just around the neck. And you're giving some clinical manifestation of the thyroid gland, such as difficulty in swallowing because they could be compressing the esophagus, difficulty in breathing because it may compress the windpipe, which is the trachea, and you can also have slight pain, and the pain is not um, common for all. And there are times you have to do surgical intervention to correct it, and partial thyroidectomy to remove it. And after they have done that surgical intervention, they will put in tracheal tube to help the patient. You have to, when they put the tracheal tube, what happens is that you either invite the speech therapist to come and help the patient, help talk back, and also eating is also a bit difficult and all that. So they are saying that if someone is having thyroid simple goiter, and we know the main underlying cause is lack of iodine. And if someone is having simple goiter, what are some of the psychological preparation you can give to this person who is having simple goiter? And the simple goiter is also part of hypothyroidism. But that one, the main underlying cause is due to lack of iodine. So how would you prepare this patient psychologically? Mariam off or she's still there? Mariam, I can see you are there. So I wanted to give you a recap. All this long talk, I was giving you a recap for you to have a fair idea what to say, what to do. Hey, hello.
Hi, sister.
Hey, I'm still waiting, no, Mary. You do hi, sister. Ebaka na atiko. Unmute your microphone and add your voice to our discussion. Any other, apart from Mariam, anybody who is ready? I will give some quiz, another quiz over the weekend before Monday. So please do well to work on it. So we'll discuss the midterm in the quiz. So Saturday, Sunday, you have a quiz to work on. The deadline will be on Sunday. I will put it on today. Then the deadline will be on Sunday. You try your hands on it so that I can get some quizzes to record as well, in addition to the mechanism, in addition to the end of semester. Okay. Oh God. Mariam, Sophia, Joycelyn, where are you? Psychological care. I will not talk on it again. If nobody contributes, I will not talk on it again. As for that thing, it's the same. So the end to us. I'm a recap. Will be as one casadia into us. It's the same, so I won't talk. Let me see the specific ones. So the specific one needs to look at regarding observation. You should check for the vital signs. Very important. The vital signs, we have the respiration, because we talked about difficulty in breathing, and respiration, temperature, pulse. We have other types of hypothyroidism, which may be caused by the adenoviruses and all that. There can be high temperature. And then agitation, that's irritation. There can also be irritation. There can be tachycardia, an increase in the heart rates or pulse rates. So when you are checking the TPR, the respiration, you are looking whether there is shortness of breath, and you're also checking whether you have high pulse rate, and then the temperature to it can also be high. Agitation, palpitations, high, faster heartbeats, and then tremors. There can also be tremors. The level of pain while swallowing, and enlargement of the treatment state, pre-treatment state. You look at the goiter before you start the treatment, so that you measure whilst the patient is on treatment. You check whether the patient is progressing or retrogressing. Now, the diet, adequate iodine is very, very essential. Currently, we have the iodized salts. So you make sure the patient has iodinated salts you use. Avoid food intake of foods which, when taken, neutralizes the iodine in the body. For example, cabbages, cauliflower, and broccoli. These foods neutralize the iodine in your food. And so when someone is having goiter, they should be reduced, or they should rather avoid the intake of cabbage, cauliflower, and the broccolis. Now, I think the broccoli is just, that's a, I don't know if you can just Google to have the images of it. Reduce too much intake of drugs such as the sulfonamides, and these also, since it's too much intake, can cause simple goiter. And avoid high seasoned foods to prevent irritation of the throat. If the food that you are eating is highly seasoned, one must avoid highly seasoned meals. The prevention, the use of iodized salts, identification of the goitrogens, and regulation of its intake, proper supervision and monitoring of iodine neutralizing diets, health education. All these are things that one can do to prevent the simple goiter. So I think that is that. All these things are easily, if you read, you can easily understand. I wouldn't want to spend so much time regarding medications and prevention, educating the patient, relatives. I think these are well self-explanatory. Quickly look at the hyperthyroidism. All these we looked at is hypo. So we are now going to the hyper. So under the thyroidisms, we have the hypothyroidism. We have so many types under it. And we now look at the hyperthyroidism. The hyperthyroidism refers to over-secretion. All that we've been doing is under-secretion. Here, the hyper is over-secretion of the thyroid hormones. And these thyroid hormones still stands at the triiodothyronine, which is the T3, and then the thyroxine, which is the T4. So the T3 and T4 hormones, when you produce it above the normal level in the blood, we call it hyperthyroidism. And this overproduction of these thyroid hormones, which is the T3 and T4, is also known as the Graves' disease, or the Paris disease, or the Base-Falls disease, or the exophthalmic goiter. It is also the second known, also known to be the second most common and prevalent endocrine disorder after diabetes mellitus. The Graves' disease, the Paris disease, the Base-Falls disease, or the exophthalmic goiter is known to be the second most common endocrine disorder after diabetes mellitus. The incidence, it affects women 8 times more than men. So the incidence, if you have 10 people, we have 10 men is to 10 women. The incidence is that 8 women will be affected more than men, with onset usually between the 2nd and 4th decade. So from the 2nd and 4th decade, from the 20s and above, usually they have this hyperthyroidism. 2 main types have been identified. The Graves' disease, most common, this is diffuse hyperfunction of the thyroid gland, and it is usually associated with ophthalmopathy. Graves' disease usually affects young women and may spontaneously subside. Sometimes it affects them spontaneously, subside. Then we have the toxic nodular goiter. This may be single or multiple and more common in older females with pre-existing goiter, unless it is eradicated or kept under suppression therapy. Causes. The exact cause is unknown. As I rightly mentioned, we have so many disease conditions that the exact cause is unknown. And among them is this endocrine disorders. If you ask, why should someone's hormones be produced excess? The exact cause is unknown. The predisposing factors are the factors that may push someone to have the high secretion of these T3 and T4 hormones in your system are thyroiditis, the inflammation of the thyroid glands. Thyroid cancer can also be another predisposing factor, and there can be also underlying infection. You know, when there is infection of the thyroid gland, of course, there can be thyroiditis or any other infection in your system that can easily affect your thyroid glands, can also result in excessive secretion of your T4, T3 hormones. Now, we have abnormal stimulation of this thyroid gland by circulating immunoglobulins, and then stress and emotional shock. When someone goes through stress, we have come to appreciate that stress, emotional problems can have diverse effects on our health, and basically all forms of disease conditions, stress, emotions, you can't rule them out as part of the underlying cause of these disease conditions. Pathophysiology. The hyperthyroidism is the oversecretion of this thyroid hormone, which is characterized by hyperplasia and hypertrophy of the thyroid gland. This leads to increased blood flow, vascularity, and size of the gland. Majority of cases of this hyperthyroidism are thought to be due to autoimmune reaction. Increased circulating autoantibodies mimic the action of the thyroid-stimulating hormone, which cause increase in the secretion of the thyroid hormones. This increase in thyroid hormone in the body may lead to abnormal rise in all metabolic processes, whose severity will determine the severity of the clinical manifestation. The hyperthyroidism ranges from mild increase in metabolic rates to severe hyperactivity known as the toxicosis, or thyroid storm, or thyroid crisis. Signs and symptoms. There's heat intolerance. This person will feel excessive heat intolerance. Just say, the person cannot just bear it. When there is hot, the environment is very hot, the person is unable to bear the effects of this heat. Excessive sweating. The person sweats excessively or profusely. There is nervousness. The person feels nervous, not feeling comfortable. Weight loss. All of a sudden, there's incredible weight loss. Despite increase in appetite, this person will be eating very well, yet there will be weight loss. Patient may have bulgy eyes. This is very, very cardinal. The exophthalmos, bulgy eyes, which produce startled facial expression. When you look at the person's face, he stares at you as if he doesn't know you, startled facial expression. And sometimes it's scary when you're looking at their face with that bulgy eyes, and then the patient is expressing their face. Sometimes it looks a bit scary. You yourself watching them, you don't feel comfortable. Emotional instability and mood swings. The patient's emotion has mood swings. Either he becomes moody, sad, all of a sudden becomes very happy. The thyroid gland may become lobular and enlarge to about 3 to 4 times the normal size. And then there's tremor and palpitations, and then sometimes diarrhea. Okay, these are the clinical manifestations. We have the diagnostic investigation. We have thyroid gland may be palpable on examination. Thyroid scan will reveal increased uptake of radioactive iodine. Ultrasound sonography confirms subclinical ophthalmology. And then thyrotropic releasing hormone stimulating test indicates hyperthyroidism if thyroid stimulating hormone levels fails to rise within 30 minutes after administration of the thyroid stimulating hormone. And we have medical management that is being administered by the physician or is being prescribed by the physician. We have the methimazole, dexamethasone, prohalothiouracil, thionamides, and others. And we also have the glucocorticoids that can be given to decrease the conversion of the thyroxine to triiodothyronine. And we have drugs like propranolol, which are also given to control manifestation of the hyperthyroidism. They act as beta adrenergic blockers. And then they can also be surgical treatments for this patient. That's thyroidectomy, the total removal of the thyroid from the patient. That will prevent to produce this T3, T4, meaning about no hyperthyroid or no hypersecretion of these hormones in the system. The nursing management still remain the same. Psychological care, have the medical that will be looking at is critical. Yeah, the psychological care same here. You observe for vital signs, observation, daily measure of the neck circumference, monitor patient weight daily because they can be weight loss. Nutrition, you plan diet with patients and probably the dietitian. Provide food high calorie with iodine. Avoid high seasoned food. which can cause irritation of the patient and bring about diarrhea. And then increase fluid intake to replace fluid loss if there is diarrhea or diaphoresis or excessive perspiration. Now, personal hygiene, you ensure patient take regular bath to reduce diaphoresis or to avoid unpleasant odor, rest and sleep. And then we have the hypothyroidism, which is also a condition whereby the thyroid gland does not make enough thyroid hormone. We have the primary, the secondary, and the tertiary hypothyroidism. And quickly, let me just go through that. With the primary hypothyroidism is a condition resulting from inability of the thyroid gland to secrete sufficient amount. The secondary is failure of the pituitary gland to secrete an adequate amount of the thyroid gland. Please mute your microphone. Please mute your microphone. And I'm making noise. Please mute your microphone. Hey, who is staying in the car and still making noise? Please mute your microphone. Hey, hello. Let me check. Who has? Margaret Ousu. Ananya Margaret. Margaret. Margaret Ousu. Okay. It's caused by failure of the pituitary gland. The secondary is due to failure. The primary is due to inability of the thyroid gland to produce sufficient thyroid hormone. The secondary is failure of the pituitary gland to secrete adequate amount of the thyroid stimulating hormone. Whilst the tertiary hypothyroidism results from failure of the hypothalamus to release the thyroid releasing hormone. Now, cretinism is a severe form of the hypothyroidism resulting from deficiency of the thyroid during fetal life or shortly after birth. So this one, cretinism, is more of a congenital disease condition whereby the thyroid hormone simply that was unable to produce this thyroid hormone. The thyroid gland is unable to produce the thyroid hormone, or the mother has usually had a deficiency of the thyroid hormone, bringing about the cretinism. The causes. Primary hypothyroidism is the most common form and is generally due to either removal, destruction, or suppression of all or some of all the thyroid tissue by the thyroidectomy. So when there is thyroidectomy, total removal of the thyroid gland, because the thyroid gland has been removed, total removal or some form of hence there will be insufficiency of these thyroid hormones in the system, or less production of the thyroid hormone in the system. For the thyroidectomy, there can be partial thyroidectomy or total thyroidectomy. And once that happens, you can either have less production of these thyroid hormones. Overtreatment with antithyroid drugs can also bring about the hypothyroidism. And secondly, hypothyroidism may also be idiopathic. You may not even know the underlying cause, and that is usually called the Hashimoto's syndrome. The Hashimoto's syndrome or the Hashimoto's thyroidism. Signs and symptoms: we have poor muscle tone, hypertonia, fatigue, constipation, depression, goiter, coarse hair, cold intolerance, and then paleness or dry, itchy skin. Late signs may be low speech, which is also breaking of the voice can also be noticed, or caused by Reinke's edema, dry puffy skin, especially the face, and then abnormal menstrual cycle, low basal body temperature. Okay, so all these are signs that may develop later. The skin will be puffy, there will be abnormal menstrual cycle and all that. Other signs may include lethargy, weight gain, complaints of cold hands and feet, thin hairs, menorrhagia or amenorrhea, either excessive menstrual flow or absence of menstrual flow, neurologic signs such as muscle acheness and weakness and clumsiness, enlarged hearts on chest ray, that's a cardiomegaly. The heart will be enlarged on chest ray. When you do chest ray, you will be observed that there has been a cardiomegaly or enlarged heart. Increased susceptibility to all hypotonic and sedative drugs. And then in severe cases, the patient will be unresponsiveness. You touch, you pinch the person doesn't respond. You talk to the person, is not responding. Bradycardia, hypoventilation, cerebral hypoxia, and then Mazy edema. All these can happen in the advanced hypothyroidism. The inadequate with the pathophysiology, the inadequate secretion of these T4 and T3 would affect the person either physically and then mentally. Okay, there is general depression of most cellular enzyme system and oxidative process. The metabolic activity in all cells will decrease, reducing oxygen consumption, decrease oxidation nutrients for energy, and producing less body heat. So these are the signs and symptoms of the disorder range from vague, non-specific complaints that makes diagnosis difficult to severe symptoms that may be life-threatening if unrecognized and untreated. The person will come trying to complain and you don't see the head and tail of the complaints. Sometimes you just need to be extra attentive and extra vigilant to be able to know what the problem might be. The thyroid gland needs iodine to sensitize and secrete its hormone. If a client diet lacks sufficient amount of iodine, the production of the thyroid hormone is suppressed for any other reasons. There's also a decrease in the thyroid hormone that leads to overall slowing of the basal metabolic activities. And this results in decrease in gastrointestinal tract, bringing about constipation and all that. And in some cases, the mobility or bradycardia, which slows the neurologic function and decrease in the heat production. So the diagnostic investigation to you do blood analysis, which will reveal low T3 and T4 levels, elevated thyroid stimulating hormone in the primary hypothyroidism, elevated of serum levels in the early stage. Electrocardiogram, ECG can help you reveal abnormal heartbeats such as bradycardia and all that. Prolonged deep tendon reflection. And X-ray, we also talked about X-rays, which can also help you to know cardiomegaly. which hasn't been prolonged deep tendon response in the ankle, previous treatment with radioactive iodine, and possible physical examination, which would reveal depression of organs and systems. The management, you monitor them and then you restore normal metabolic activity such as the thyroid hormone, example, administering of these thyroid drugs, levothyroxine, thyroglobulin, and the Liotrix. All these are thyroid drugs which can. Then you monitor to anticipate any treatment effects. Is there any diuresis, decreased puffiness, and improved reflexes? The nursing care risk for imbalanced body temperature. Then that's just a diagnosis by its. So with the management, I think it's virtually the same. So we are ending this under the thyroidism. We talk about hypothyroidism. We've talked about hyperthyroidism. And among the hypothyroidism, we have indicated that we have simple goiters, and this simple goiter, the main underlying cause can be due to lack of iodine in the system and all that. And we also looked at the hyperthyroidism, which usually we have is also known as the Graves' disease, and in other instances, we've also looked at the cardinal clinical manifestation where we have the exophthalmos and all that. So for now, I would want to end here. If you have any questions, please ask. We are done with the endocrine system. We've looked at diabetes as well as thyroidisms. And so these are, and then the thyroidism, the main cardinal ones that you should concentrate should be the hypo and then the hyperthyroidism. These are the main that suggests your course outline suggests we look at. But we just looked at some few endocrine conditions. We have the pituitarism and all that. And I think we are ending here. If we don't have someone, Emma Kwame, you have raised your hands. Any question? Emma, the floor is yours. Unmute your microphone. Let's listen. Yeah. Yes.
Mention of the radioactivity. Is it radioactivity something? Iodine.
And that's the diagnostic investigation. Is it that of the hypo or the hyper? Let me see.
Well, I think it was with the hypo.
Okay, let's go there.
Madam, with the treatment. I only heard of the iodine solution being used to treat. But now I have seen about 3 different medications brought out in the presentation. They no more use iodine solution again. Iodine solution.
Which of them are we using the iodine solution to treat?
Currently, I think it was the person had the needles that is around the neck region.
Okay.
So she was given iodine solution from Kolobu.
Okay.
So she would put it in the water and she would drink it.
Okay.
When I asked, she said it's to suppress the gland from being enlarged, as you said earlier on.
Okay.
But she was not giving any other drugs, but it was in your presentation I heard that there is more than 2 to 3 drugs that can be given to them.
Yeah. What happens, there is one thing we must appreciate when it comes to medical treatment. you start with the first line of treatment, you go to the second line of treatment, and we move to the third line of treatment, on and on and on. So we've exhausted all the treatment regimen. So one thing you must appreciate is that the iodine treatment is not the only guarantee measure to correct that anomaly. That's the hypo. I'm sure that person might be having hypothyroidism, sort of, or was there any goiter? Did you see any enlargement of the
The
thyroid
enlargement,
gland?
it was not all that big,
Big.
like the
Okay.
ordinary person that
Okay.
is.
You see. Okay.
It
Okay.
was something.
But you could see that the thyroid gland is a bit enlarged, right?
Yes.
Exactly.
Unless
And
you are very
so,
close to, if you are not close, you don't even see.
so let's look at the classification of the hypothyroidisms. We have one resulting from the inability of the thyroid gland to produce or to secrete sufficient thyroid hormones in the system. So let's assume if this individual is having the primary hypothyroidism, of course, wouldn't be the complicated one. Then only the iodine can resolve the problem. But now let's go to the second type of hypothyroidism. If it is caused by failure of the pituitary gland to secrete adequate amount of thyroid hormone, this can also probably may be corrected with just the iodine, not just the iodine, but you have to add something else to it. And if you look at the third one, he's saying failure to release the thyroid stimulating hormone. And here in severe form can result in the thyroid during the fetal life or shortly after birth. That is, this cretinism is usually affect the children or the babies. I'm talking about here is about a pregnant woman who is having the hypothyroidism, thyroidism, and this can make the child have a condition called cretinism. Usually, if a child is having cretinism, the child is unable to thrive or develop well, and it also has its own impact. We have its own clinical manifestation. So this is also another condition with the neonates. If you are looking at the treatment modalities here, if you are looking at the treatment, this is just the course. And in medicine, there's one thing we should appreciate. You have to know the underlying cause. If you know the underlying cause and it's only due to the thyroid gland unable to produce enough T3, T4 hormones, which would help in the reuptake of these iodine, then you can now give only the iodine. But if the underlying cause is due to something that is causing destruction of these thyroid gland, you can't just give the iodine to correct that. I hope you are following the discussion.
Yes, please.
Let's look at the treatment. I just want us to move down to the treatment modalities here.
Yeah, stop shouting, stop shouting.
Management.
Yeah, lower the TV set. Yeah, Indy.
So here we are saying that when you are giving the thyroid hormone, so these are the ones as to how you said the person would rather dissolve and drink it. We have other types that might not be even the dissolved one and all that. So depending on the severity of the thyroid or the deficiency, that would really depict or that would tell us how we should rather take care of our patients. And we have instances that sometimes we give symptomatic treatment depending on the symptoms that the individual is depicting. It will tell us whether we should add further treatment to it or not. I remember during the clinical manifestation, I said in some cases the patient will have pain. So if this patient never experienced pain, there will be no need for analgesics. In some cases, it might even be due to underlying infection or bacterial infection. If the underlying cause doesn't have any bacterial-related infection or viral infection, this patient wouldn't need any antibacterial or antiviral treatment. So all them treatment modalities, there's one thing we should appreciate. We must know the underlying cause, and based on the underlying cause, it will tell us whether we need to give antibiotics, antiviral medications, or just give the iodine supplements to correct the anomaly. And there are other times that if all these treatment modality was still not correct, you will need to resort to surgical intervention. I think along the line, I did talk about surgical or surgery as an option, depending on the outcome of the medical management. So I believe I have answered your question. If not, you can further ask if you are not cleared with the explanation or any other question? So Emma, look at this statement. The treatment depends on the size and the cause. Are you following?
Yes, please.
The treatment depends on the size and the cause. So always remember, in all medical treatments, it's not just about the size, but the underlying cause is one of the major way of treating any medical condition. Knowing the underlying cause is one of the major way of treating a medical condition. And we mentioned here that it requires administration of iodine preparation, which is also very important. Iodine preparation. And we said an operation to remove some or all the thyroid gland may be an option in some cases. So surgery is not all cases. In some cases, you have to remove either all or even part of the thyroid gland to correct this anomaly. And we mentioned these radioactive preparations. You can either drink it or swallow. Some are in the capsule form, some you can dissolve it and then you drink it to correct it. When the treatment of simple goiter during childhood to puberty may be given adequate iodine diet for 1 to 2 years. So here, a child from the childhood stage, if it is a child who is experiencing it and it's in the early stage, you can give only adequate iodine diet. That will be enough. You don't even need the preparation. The diet alone can help correct it. And the multinodular simple goiter, which is unresponsive to the oxygen, is being operated. So if someone is having a multinodular, it's not simple one, multinodular simple goiter, and the person is taking the iodine preparation, yet the iodine preparation, the person is not responding to the progress, the patient is not progressing, then operation or surgical intervention is now become an option. Are you following? And that is why we term as the thyroidectomy. The thyroidectomy. So we can have either partial thyroidectomy or total thyroidectomy, depending on the severity of the goiter and its impacts on the individual who is suffering the thyroidism, the hypothyroidism or the hyperthyroidism. So these are the explanation I can give to your question. I believe I've added more voice to what you really wanted to understand. Okay.
Sister, please that with typhoid, it's only with a female. Because I've never seen a male with a typhoid. Is it because I think most of the time
thyroid.
they all do
Thyroid.
Yes.
And that's why we gave the ratio. Ratio is 8:1.
Yeah,
It
because
is
I've never seen a male with a thyroid gland
you
with a typhoid, hey, thyroid
thyroid,
before.
and they have it. They have it, but it's not common. They have, but it's not common. Unless you start doing the study, you can't conclude that you. Okay, you as an individual, where you are coming from, you have never seen it, but that doesn't mean they don't exist. Are you following?
And madam, with that too, it always happens mostly in the rural area, not even
Mm,
in the urban area.
are you sure?
What I observe, yes.
Oh no, 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 no. This one, most okay. If we talk about mostly, well, that can be appreciated. But the urban is still there. We have people living in Accra, Kumasi, and they are still having this thyroidism. So it does happen to everybody depending on the way your dietary lifestyle, your hereditary. We talked about the underlying causes and we mentioned hereditary. If you have a family trait and you are living in US, you can still get it, you know.
Okay, I
Aha.
see.
So we have so many underlying causes that can predispose an individual to this condition. So based on where you are coming from, if you are in the rural setting in your family history, there's nobody having this thyroid um, deficiencies or hyperthyroidism, you can still not have or you can still not be exposed to this condition. And also we have other dietary lifestyle and all that. If your dietary regimen is okay, you inculcate iodine foods in your food. If you prevent food that prevent absorption of iodine in your food, such as the broccoli, the cauliflowers, and all that, you can still be protected, or you wouldn't have thyroidism in your system. Any other question?
No, I'm okay now.
Okay. Mariam, are you still there? Yeah. Oh, yeah, I was in the next rep part. Can you again? Last rep. Hmm. Is the class, are we okay with what we have presented so far?
Yes, sister.
Okay.
Nana, you fall down.
All right. So I think we've had so much, we had a lengthy discussion on diabetes. Let's do a quick recap of what we've done so far till now. Then we'll end the class. Judith Mamle, are we there? The first question goes to you. What are the three cardinal clinical manifestations of diabetes mellitus? Judith. Mariam. Pokia Ellen. The question goes to any of these three. What are the
Yes, madam.
what are the three main cardinal symptoms of diabetes mellitus?
Madam, I'm trying.
Yeah, try.
Madam, frequent urination,
Okay, one.
and then excessive thirst,
Excessive test, that's good too.
and then weight loss, weight loss.
Okay. All right. So weight loss doesn't fall with the three main P's. We have three main P's, even though weight loss is also important. But the three P's Can you use the terminology that rightly describe the three P's?
Yes,
The
madam.
test is what? How do you describe it? Yes. You know, if you will be okay.
Madam, the first one is polydipsia.
So the polydipsia
And
is
then-
what? Is which one? The excessive what?
Taste.
Okay.
Drinking.
Yeah.
And then polyuria, which is urination.
Very good.
And then polyphagia, which is appetite, loss of appetite.
No, not loss. Excessive appetite. Or did you have
Excessive. Okay.
gets hungry quick and he eats very fast? That's good.
Yes, please. Thank you.
Okay. Talker Millicent, Mariam, you haven't still answered any questions. So this question you are still part. Is it Ellen White who just spoke?
Yes, please.
Okay, so now Margaret Owusu, Talker, and then Mariam. The next question. What are the 4 main treatment modalities for a patient with diabetes mellitus? The 4 main treatment modalities.
Hello, sister.
Yeah.
Controlling blood sugar.
Okay.
Regular screening.
The screening and the blood sugar is the same. Constant monitoring of the blood sugar is part of the screening. Okay, so the second point is
Start their diet.
Some medications.
medications. Okay. So under the medication, we have what and what?
We have the insulin.
Yeah, the injectable, which is the insulin, and the oral, where we have the metformin and the others. Okay. Okay, so we have 2 now. You've talked about monitoring. You've talked about medication. What's next?
Exercise.
Regular exercise, which is very important. Then the 4th one.
The diet.
The nutrition aspect.
Diets. Very, very important. Okay. Now, let's go to, what is the normal fasting blood sugar? The normal fasting, okay, I didn't give you the normal fasting blood sugar, but at which level would you categorize your patient is having diabetes? When you check your sugar level of your patients and you are monitoring the blood sugar of your patients, at which level will you say that your patient is having diabetes? That's, I'm talking specifically to
please, when it is 2
when
Sister, please, when it is less than 2.2 millimole per.
No, that one is hypoglycemia. When it is less than 2.2 millimole, then it means your patient is having hypoglycemia, and that is an acute chronic complication whereby your patient can go into a comatose state and will need a severe intervention to correct it. Otherwise, your patient can die. So that figure is cardinal to hypoglycemia. I'm saying that when your patient comes to your facility and you check the sugar level, at which level can you now confirm, maybe plus the 3 P's, and you are now checking the fasting blood sugar, at which level will you confirm that this patient is diabetic?
Madam, when it is around 7,
When it is
When it
more
is
than
than
7 millimole per liter. Millimole. So your unit is very important. Millimole per liter. What of the random blood sugar?
random blood sugar would be 1 millimole. When it is more than 1.1 millimole per meter.
Yes. The random blood sugar when it's more than 1, that is 11.1 millimole per liter. That's very good. Now let's move to the thyroidism. Another name for hypothyroidism is what?
Madam, another name is hypo mean less.
You're on track. Less what? So you are on track. So less thyroid hormones. And these thyroid hormones, we have the triiodothyronine and then thyroxine. T3 and then T4. So when there is less production of the T3 and T4 in your system, we say you have hypothyroidism. But I was asking for another name for hypothyroidism. Hypothyroidism. So you cross-check that. And another name for hyperthyroidism. I wouldn't want to be giving you answers to all. Obisa neno mo plan na monya maji. Mo kanche. Obisa sister Nina, why? Another name for hyperthyroidism. That one is also the high secretion of the thyroid hormone, which is the T3 and T4. You have 4 main types or 4 main names: Graves' disease, Paris disease, Baseballs disease, or the exophthalmic goiter. Exophthalmic goiter. Okay, so we'll end here without much question. Do you have any more question?
No, madam.
Okay, so I think we can end the class here.
Thank you, sister.
Without any further question, we'll end the class here. So take care of yourself, stay safe and stay blessed. This weekend, please check your class model. I'll be leaving another final quiz there for you to try your hands on, and then we'll discuss all that, God willing, Monday with our answers, so that you still sleep by it and read extensively whilst you still prepare.
Weekend. Is it the exams will be weekend?
And I'm on penisa. Me fambra na menye ni da fufuro. Which one?
Sister, is it an assignment or quiz?
Quiz. Not assignment. Assignment, then you go and upload. Go and do.
Sister, is it on medicine or?
Any, both, 3. It can be any of the 3. Major ni na ebi. You do all concurrently. Oh my god. Okay, I do. So when should I put it there? Today is next week. Weekend is what? And I should give it to you on Tuesday. Then you work on it Wednesday and Friday.
Yes, yes, yes. Yes, madam. I
Hey,
want it.
you want it when? The way she did
Sister
yesterday.
Tuesday.
Tuesday, okay.
Yes, madam. Yes, madam.
I hear.
So fire, so fire.
So far, you said we say aggressive, crab, Hey, it's a weekend. You only adaje. You don't have adaje, and you don't have time for quizzes. Don't worry.
SD, so far SD ni.
You mate. So God willing, I'll put it on Tuesday, God willing, and then you try your hands on. Then later, if I'm unable to give you the answers, I'll give you your notes so you check your answers. It could be online or whatever. Hmm? All right, but I'll record your marks, so make sure you do a very good work. You read well, prepare well, and then come and do your piece. Okay.
Madam,
Oh,
please, please
Okay.
to be around what we taught today.
oh, everything, my dear, could be plus everything we have taught.
Sister, is it surgery? Is it surgery or medicine or both?
Mariam, BBB.
All the
Hey, ask one question.
Sister, see person.
Slides.
You baby.
Nti monhyia ne nyinaa saa berɛ ɛwɔ sɛ mo prepare for biribiara makɔto aba awie moagye mo ani awieɛ deɛ aka no momfa nsua adeɛ nti all the three.
Sister,
Yes.
sister, please, on Tuesday, we have community health mission.
Mid-sem Tuesday.
Yes, please.
So I should put it there when Friday.
Yes, please.
I hear. I'll do that for you on Friday. God
Thank you.
willing. Okay.
Thank you, sister.
You're welcome.
Sister, please, you have
Uh-huh.
to send us slides too. Today's slides. Please don't forget.
I hear. I will send it to you. You and your slides, you don't joke with it. You and Mariam, I will send it. Why?
So that if you don't check anything from the discussion, at least you can read to
Yeah, that will be
get
fine.
something.
Yeah, that will be fine. I'll send the slides to you. Okay. So please, any other concerns so far?
No, you're hungry. Oh.
No comments.
You're hungry.
You're hungry. Me too, I'm more than hungry. My children are even crying. All right then. Then we'll call it a day. Stay safe and stay blessed.
Thank you, sister. Same to
Okay.
you.
Bye.
Bye. Where is Nana?
Monday. My mother went for a show. That's how I do it. When I was doing it, like this, one show. Oh my God, show. Oh, mama, oh, I did it. Oh, mama, oh, man. Me kotu baby dawo. Never fight dawo. Ajipino. Never debitano. Elizabeth. Arriba. Awa. Onda Tiana. Adventiana. Mommy. Uh, 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 uh,